Ladies and gentlemen, Assalamu alaikum and good morning. My name is Hassan Said and I'll be your host for today. I welcome you all to this webinar to mark the launch of Karandaaz's study on the private healthcare industry in Pakistan. We encourage everyone to share their thoughts on today's webinar using the following hashtags: hashtag healthcare, hashtag private healthcare, and hashtag KRN webinar. The proceedings of this today are that we'll have welcome remarks by Mr. Waqasul Hassan, CEO Karandaaz, and opening remarks by Dr. Shamshad Akhtar, Chairperson Karandaaz, followed by a keynote address by Ms. Fatma Sheikh, who is the Special Secretary Development, Finance and Reforms in the Primary and Secondary Healthcare Department, Government of Punjab. During the course of this webinar, we'll be sharing findings from the report in the shape of a presentation and hopefully a small Q&A session after that. And then we'll have two panel discussions focusing on bridging the infrastructure gap through innovations and navigating the landscape of financing in the private healthcare industry in Pakistan. Lastly, we will conclude the webinar with remarks by Ms. Anna Gibson, who is a Senior Private Sector Development Advisor at the British High Commission of Islamabad. To begin the day's proceedings, I would like to welcome Mr. Waqasul Hassan for the welcoming remarks. Mr. Hassan has a rich experience in designing and implementing a wide range of development finance programs. He has a special interest in climate-related investment and regulatory reforms, seeding innovations, entrepreneurship, and establishing key institutions that impact the financial landscape in the country. Mr. Waqas, please.
Bismillah ar-Rahman ar-Rahim. Can you hear?
We can hear you.
Thank you very much, Hassan. Bismillah ar-Rahman ar-Rahim. Thank you, Hassan. Dr. Shamshad Akhtar, Chairperson, Karandaaz Board, Ms. Fatma Sheikh, Primary and Secondary Healthcare Department, Government of Punjab, Ms. Anna Gibson, esteemed speakers and valued. It's an honor to extend a welcome to all of you. Today we have convened to discuss the pressing issues relating to healthcare delivery and specifically the role of the private sector, how it can be augmented, what is required to make it more effective, and how can possible synergies between the public and private sector to improve the healthcare delivery in Pakistan. Karandaaz is an impact investor, and we try to focus on such development gaps in Pakistan which need risk capital. Healthcare is one such area. I have some statistics with me, but I would like to share a story with you first from my recent past, which will say it all. Back in December 2020, some early COVID vaccines had already come to the market. The rich nations were buying them whilst we were waiting, either getting Chinese vaccines or waiting for COVAX, the global facility which was set up for bulk buying and equitable access to vaccines. Here is an important figure which I would like you to note. Roughly 43% of the entire global vaccine production at that time, and I think still, came from three pharmaceutical manufacturers in India: Serum Institute of India, Bharat Biotech, and Biomed. In vaccine production, the hierarchy can be divided into four types of players. At the top are API or active pharmaceutical ingredient manufacturers, who have the research capability and create the actual DNA of the vaccine. Then comes bulk manufacturers who produce vaccine. Third are fill and finish, who basically convert the bulk into ampoules and syringes. And finally, the distributors. You'd be surprised that even today, Pakistan is struggling in the second tier, fill and finish, let alone moving to bulk or to the API manufacturing category. Long story short, while supply from COVAX was months away and millions were at risk in Pakistan, both the public and private sectors started looking for alternatives. We learned that a South America-based bulk and toll manufacturer had access bulk which could be shipped to Pakistan and distributed locally after fill-finish facility through our partner Bago Feroz Sons, which Karandaaz had invested in for fill and finish capability. It looked quite simple. Bulk is available, buy and import it and convert into ampoules through fill finish and market it. No subsidy was even required because people were willing to pay for it. There was one catch, however. The international pharma industry is organized in a manner that each CMO or contract manufacturing organization or toll manufacturer for simplicity is allocated a region, and no CMO from other region can cross-sell to someone else's region without the permission of region's own CMO, which in our case happened to be an India-based manufacturer. Then started diplomatic and private sector efforts spanning over months, but we failed to procure this permission. I recall and relate to you the last meeting we had with the regional office of one of the global pharma giants, under whose license the Indian manufacturer was manufacturing the vaccine. We made a very passionate plea that millions were at risk, and got rather a blunt reply from a senior Middle Eastern executive, and that was, "Brother Waqas, we hear you, but that's how word works. Nations which have invested in capacities over decades enjoy these privileges. Contractually, we are bound, and there is nothing we or you can do about it." That finished the argument and our search for buying the vaccines from the South America-based manufacturer. This is true for vaccine manufacturing, not only for vaccine manufacturing, but most of healthcare segments are perhaps wider than that, but healthcare is critical. The message I took back was, if you want to be self-reliant, invest in your capacities. Now I come to some figures which would underscore the fundamental challenges that confront our healthcare system. The United Nations has set 17 Sustainable Development Goals, and healthcare is the third one. Between 2010 and 19, Pakistan's universal health coverage index increased by an average of 1.2% per year. Although progress has been made in enhancing healthcare provision in Pakistan through the efforts of public and private programs, there is still much work to be accomplished. Regrettably, Pakistan's score ranks as the second worst in South Asia, ahead of Afghanistan only. In comparison to global figures for hospital beds to 1,000 patient ratio of 2.9, Pakistan severely underperforms on this metric with a ratio of 0.6. In terms of universal health coverage score, Pakistan ranks second worst in South Asia. Pakistan spends $37 per capita on health, which is lower than the WHO prescribed level of $44, a minimum spending package required for essential health services. In comparison, emerging economies such as India have a health expenditure of $57 per capita. While maternal mortality ratio and mortality rate under 5 has improved over time, it is still high in comparison to the regional average in South Asia. Pakistan faces a complex health profile marked by high population growth rates, infant and maternal mortality rates, and double burden of communicable and non-communicable diseases. However, the supply of health facilities remains insufficient to meet the needs of the growing population, resulting in low supply coverage. Adding to the condition, the health system is frequently disrupted by recurrent disruptions from acute crises and disease outbreaks, such as the COVID pandemic. These challenges are compounded by chronic factors such as low GDP allocation to the social sector, sluggish economic growth, ongoing conflicts in certain regions of the country, and overarching governance challenges. With the mounting population pressure on state health institutions, the private sector has taken an increasingly important role in the delivery of healthcare services to address the widening gap between soaring demand and limited public health facilities. The private sector's notable growth is evident in the substantial increase in the number of private hospitals, clinics, and diagnostic laboratories. However, despite growth of private healthcare in Pakistan, there are still significant gaps in healthcare systems, which are rooted in structural flaws. For instance, while public sector hospitals are the primary providers of critical hospital admissions and medical care for the underprivileged, routine consultations are sought by 70% of Pakistan's population from private medical providers. Private healthcare provision mainly focuses on tertiary care hospitals, resulting in a neglect of primary and secondary healthcare. This unbalanced system has resulted in inadequate emphasis on primary and secondary healthcare, hindering their effective delivery. Furthermore, there is an incentive problem where private providers tend to invest in profitable facilities such as obstetrics and gynecology, rather than specialized facilities for infectious diseases and diabetes, which have a greater contribution to the disease burden. As a result, there is an overinvestment in the former and underinvestment in the latter, hindering the effectiveness of the healthcare system in reducing the overall disease burden. People familiar with the tertiary healthcare in Pakistan would agree that the introduction of latest medical practices and specialties in Pakistan over the last couple of decades at least is not because of any systematic plan by public or private sector, but largely due to top quality doctors returning to Pakistan with the spirit of giving back to the community. It's a good way of availing of their expertise, but not a very reliable way. Now that I'm speaking, Karandaaz is also exploring investment such opportunity in a world-class neuro hospital being set up by leading neurosurgeon Dr. Irfan. Whilst Karandaaz actively looks for such opportunities, the fundamental point is whether an efficient mechanism of technology transfer in healthcare exists in Pakistan, and the answer is no. Karandaaz is invested in Excel Diagnostic, a respected diagnostic chain. An year or so ago, Dr. Rasheed shared with me that the unique test offering of all diagnostic chains in Pakistan, and that includes Khan, Shaukat Khanam, all respected diagnostic chains, put together will not be more than 1/3 of the tests offered by one top quality lab globally, such as the Doctors Lab London, TDL, commonly known. As a result, either we send our samples abroad for testing, losing precious foreign exchange, or our patients simply don't get tested and pay through reduced or poor quality of life. I can go on and talk about issues of inequitable access, standards of healthcare, pricing issues, and regulation of healthcare, but I'm sure speakers today will talk about these in much more detail and with higher levels of granularity. Is there some good news? Yes. The sheer size of middle class in Pakistan, their expectation for higher healthcare standards, willing to pay for those, the innovative and successful public-private partnership experience which through Sehat or Health Card governments across the country are doing, and the quality of medical education are all good, great news. The fundamentals in the form of demand, aspiration, and capabilities are in place. As I said at the outset, Karandaaz is an impact investment platform. Healthcare is a central pillar of our investment strategy, and the board has given us strategic direction to identify and invest in healthcare where private capital is shy to come in, and additionality can be justified. We are at present invested in pharma and diagnostics and continue to look for opportunities. We would need both the like-minded investors and reliable, credible sponsors whom we can partner with. I would like to thank my sponsors, FCDO in particular, without whose support we would not have been at the place where we are, and for setting up this platform which enables us to serve the country. I would thank SERB for leading a consortium of firms to undertake this valuable research, which would push the needle of knowledge in this area, and my team, Meher Shah and Ali Akbar from the research, marketing and communications, who oversaw the entire process and has worked tirelessly to make today's event possible. My profuse thanks to the chair, who despite her busy schedule, always finds time to provide strategic advice on the board and supports us with her presence and thoughts in these policy dialogue forums. Thank you, and over to you, Hassan.
Thank you, Mr. Waqas, for your valuable insights. And now I would like to welcome Dr. Shamshad Akhtar, Chairperson Karandaaz. In addition to a broad-based international development career, Dr. Akhtar has served as Finance Minister of Pakistan, as well as the Governor of the State Bank of Pakistan. She is a member of the Advisory Board of the Sustainable Finance Center in the UK. She remains engaged in both global and national policy dialogues and is the global advisor for the Belt and Road Initiative. Dr. Shamshad, if you could turn on your, yes, please. Thank you. Over to you.
Thank you, Hassan, for your excellent moderation, as I can see. Bismillahirrahmanirrahim. Assalamu alaikum to everybody. Honorable Special Secretary, Ms. Fatma Shah, I know that you are probably handling development, finance, and reforms, a number of things. So it's great to have you from Government of Punjab. And also, I'd like to thank all the other participants for joining us. Most of all, I'd like to thank Waqas for his excellent laying out some of the critical challenges and substantiating it with some evidence that he has confronted. Karandaaz is an organization that is building its knowledge across critical sectors and also diving into sustainable development goals. And one strong illustration of that is this presence session. So we are proud to launch this study of the Karandaaz on the private healthcare in Pakistan. It's a very critical SDG goal. Like other developing nations, Pakistan, of course, encounters formidable hurdles in the realm of social services, most of all healthcare, a very sensitive area. The nation grapples with twofold challenges, to put it simply, characterized by high incidence of both communicable and non-communicable diseases. About 15 million people are affected by hepatitis B and C, and the country ranks 5th in the incidence of tuberculosis across the world, and so forth. One can go on. Non-communicable diseases such as diabetes, cardiovascular conditions, and respiratory illnesses account for approximately 60% deaths. This is a significant burden of communicable. There is a significant burden of communicable diseases in neonatal conditions. Meanwhile, the healthcare system suffers from insufficiency and, to some extent, misalignment with the overarching national healthcare objectives. The national vision of 2025, 2016 to 2025 for Pakistan provides a response to various health challenges, anchoring, of course, universal health coverage as its ultimate goal. There are problems with the way this is being designed. I can say that from my Asia-Pacific experience. Thus far, there has been modest improvement in some basic indicators of SDG 3 of health and well-being. Universal health coverage has gained ground through Sehat Sahulat Card, expanding health infrastructure, including number of hospitals, rural health units, and basic health units. Major gaps, however, still exist in healthcare governance in terms of the quality of infrastructure or innovation or lack thereof innovation, absence of equitable access, and there is need to exploit cross-sectoral synergies between private and public sectors. Acute crises such as the COVID, which has been referred to by Vakas, the pandemic really hit us badly and took us by surprise, lack of preparedness, and 2022 floods, which has had a substantial part of Sindh and Balochistan province under the water and still struggling to lift their heads up. The weak healthcare systems have been overstretched, and they have exposed inherent weaknesses in infrastructure, policy, finance challenges, and it has all been very disruptive in terms of the effect on the priority areas of healthcare, as well as resource allocation and the poor efficiency in terms of the use of resource allocation. Pakistan has a mixed system of large government infrastructure, of primary and secondary health facilities in rural, very urban areas, and large teaching hospitals in urban areas. Over time, private sector healthcare has grown in response to high population demand It mainly focuses on tertiary healthcare. NGOs and the philanthropic sector have played their part in delivering mostly preventive services. However, the efficiency of the overall healthcare system is limited due to the siloed development of private and public healthcare systems, or for that matter, siloed approaches between primary, secondary, and tertiary. There is virtually no interface and connectivity, which has resulted in what is today a fragmented system with idiosyncratic challenges and misaligned priorities. As a result, Pakistan's Universal Health Coverage Index is ranked second worst in South Asia, indicating supply coverage being extremely low despite high demand. I sometimes wonder whether during our lifetime we will stop calling us as the second or the first worst in South Asia. And I think endeavors like these, if taken to their logical recommendation and conclusion, shall help us lift the ranking of this country and bring prosperity to our people. Enabling elements that target real demand and supply are non-existent in the market. We all know Pakistan's population has grown phenomenally. It has been one of the basic problems of this country, whether it's to do with macroeconomic imbalances or it's got to do with the social delivery, social services delivery. The population has grown on an average 1.8% per year between 2010 and 2020. Healthcare's expenditure as a percentage of GDP has barely risen from 2.4 in 2010 to 2.995 in 2020, with out-of-pocket expenditure accounting for more than 55% of it. Now, this is despite massive fiscal deficit that Pakistan confronts. What it does is to compress the development expenditure and gives the least priority to the social services. And with the devolution that occurred in terms of the 18th Amendment, it's all with the provinces. So it's very much in the hands of the provincial governments now to lift the game. And I must say, there are resources available there at the provincial level. I am first a public finance person, then my diversified economic background. My first career was in public finance. So I have firsthand had knowledge of both the federal and provincial government finances and how public financial management is one of the poorest elements. And the devolution, of course, helped to expand the transfer of resources to the provinces, but at the same time transferred all the social services, bulk of the social services under the geography to the provinces. Despite all these reforms, underinvestment in healthcare and the lack of well-coordinated private health services needs to be addressed. For instance, health insurance can significantly boost the real demand of healthcare services and contribute to private-led growth. However, about half of the population does not have health insurance coverage. Furthermore, there are structural issues. The private healthcare sector is primarily comprised of sole proprietorships of specialists, doctors that provide tertiary healthcare, while public healthcare facilities are the go-to go to for primary healthcare. If I can excuse myself for 1 second, I think I am having some light problem here. I apologize for that. So I'm trying to fix that. Sorry about this. Further, let me take myself to the last part. As I said, there are structural issues. The private healthcare sector is primarily comprised of sole proprietorship of specialist doctors, is what I said, that provide tertiary healthcare, while public healthcare facilities are the go-to for primary healthcare. There is an evident lack of focus on accessible secondary healthcare, especially in rural areas. This conundrum is multifaceted. One, secondary healthcare acts as a referral point for patients who require specialized care beyond the scope of primary healthcare. A lack of secondary healthcare hinders the functioning of a referral system that requires patients receive right care backed by right expertise and efficiency in resource allocation mechanism, and provide access to advanced diagnostic services for early detection of diseases such as even cancer. Public facilities often lack technical and resource capacities to offer such services, and larger private facilities are less accessible in rural areas given the lack of affordability by patients. These factors have severely constrained the management of chronic health dimensions and conditions, monitoring disease progression, and coordinating long-term care plans for patients in Pakistan remains a challenge. So the Karandaaz study in front of you is one of the most extensive scoping of private healthcare landscape. It shows that cost of doing business in private healthcare sector is extremely high, with an estimated cost upwards of $20 million for setting up a modest tertiary facility and a 100-bed hospital, estimated to having a requirement of 5 to 6 million working capital per month. I have to say, since I came back to Pakistan in 2018, I have been dealing with a couple of patients in my family. And I can tell you that I was using a private hospital, and I think you need an ATM which is funded by outside source to be able to finance the healthcare that you want to give to your family. So since I don't have such a heavy ATM backing, it has been quite challenging to be even drawing on the private healthcare facility. And when you look at the public health facility, it has its own challenges in terms of quality and having the consultants who work there doing multiple jobs. So high investment and working capital requirements and limited excess capital are major barriers to growth for small and medium scale health enterprises. The inability of such enterprises to reach scale economies translates to higher pricing, which in turn limits private healthcare providers from expanding their market share or penetrating other markets such as primary and secondary healthcare, which are volume dependent. High cost of doing business not only limits profitability and scalability, but also leaves little room for a pro-poor approach to healthcare delivery. In such a scenario, return on investment dictates healthcare supply rather than disease burdens. It would be logical to assume that the private sector would cater to healthcare demands of higher income groups rather than being adequately responsive to diseases that have a greater burden on masses. Another issue is limited access to investment. As we know, credit allocation to SMEs, including those in healthcare businesses, by the financial institutions is extremely limited, about 6% of the total private sector credit. At the same time, capital markets in Pakistan are extremely underdeveloped. So this leaves small-scale proprietors or family-run private healthcare providers unable to grow or compete with large ones. Corporatization is, of course, more complex for the small enterprises than the large ones. Government's incentivization for private healthcare is almost lacking. It would be a good way to shift the financing burden. Public sector interventions such as subsidizing the cost of land acquisition for medical facilities, as observed around the globe, should be introduced. On the technology front, tech-enabled interventions in healthcare sector have been relatively well received by consumers and even investors. Digital healthcare platforms such as Marham Park yet are limited in scope, and outreach, investment, and involvement of technology and IT sector in healthcare is crucial to bring transformative change in the industry. For instance, a technological intervention may be required to enable the interoperability of data and medical records. Such a system would bring patient records up in a single click and allow automatic transmission to relevant doctors. The interoperability of data and medical records would create significant convenience for consumers and also reduce costs of accessing healthcare through minimizing repeated medical tests in order to reproduce medical records. And I can go on with a lot of other issues, but let me conclude by talking about the lack of regulatory and industry level standards, which has undermined quality of private healthcare in Pakistan. Effective supply of quality healthcare makes total business sense. Availing of this opportunity, health tourism has been exploited, and I have been in Thailand prior to 2018, where health tourism is thriving. And there are other countries too. In India, they attract 2 million patients each year from 78 countries for medical, wellness, and IVF treatments, generating $6 billion for the industry, which is expected to more than double by 2026, backed by India's HEAL initiative. Pakistan can develop its potential to promote quality private healthcare and target global consumer markets in an innovative manner. And we are hoping that Karandaaz can spur this activity through some piloting of some programs. Among others, it will help retain high-quality healthcare workers within Pakistan, which move abroad to look for better opportunities. And of course, it will help increase FDI in local healthcare sector by international investors and drive up valuation of private healthcare facilities in the country. Another important area which requires our attention is identifying and addressing existing gaps in underserved markets. It requires full force entry of private sector backed by proper diagnostics, high quality labs and equipment, and incentives to enhance the health infrastructure and services. Establishing a network of primary care facilities in these cities and small and medium scale specialized primary care hospitals in peri-urban centers is critical to offer the required specialist facilities that yield a double bottom line return. This will help reduce the burden of primary facilities gaps being transferred to the tertiary facility that is not only costly but entails high opportunity cost to the healthcare. There's need for tertiary sector to focus and strengthen treatment for specialized health problems backed by teaching facilities that train and provide specializations to the doctors. And I don't mean train 10,000 people, but train millions, because that's the size of our population. So let me conclude. Karandaaz research, marketing, and communication deserves all the credit, and our colleagues and the team that has worked incredibly hard to make this study a reality. And also to get this webinar going to discuss, identify challenges and technology and financing domains to offer solutions plagued in Pakistan, our health system. I can tell you that if we don't move towards sustainable development, we will never have prosperity in Pakistan, because a healthy person can enhance the productivity of this country. Thank you so much.
Thank you, Dr. Shamshad, for your valuable insight into this. I would now like to welcome Ms. Fatma Sheikh for the keynote address. She is currently serving as the Special Secretary Development, Finance and Reforms in the Primary and Secondary Healthcare Department in the Government of Pakistan. Previously, she was serving as the Director General Child Protection and Welfare Bureau, Home Department. Ms. Fatma, please, if you...
Assalamu alaikum ji, and a very good morning to everyone, and especially it's an honor to share this platform with Madam Shamshad. She has been an ideal for so many like me, myself in financing and otherwise. She is a torchbearer of a lot of good initiatives in Pakistan. Now, one small correction. I am not Special Secretary Development, Finance and Reforms for the Government of Pakistan, but it's Government of Punjab. Primary and secondary healthcare, Government of Punjab. Well, there are a lot of things that when Madam Shamshad was setting the stage for the report to be unveiled, I would just give whatever little experience that I have had since 2017 in bits and pieces of the health financing and how the health is financed in Punjab and where the problem lies exactly. So I would speak from that perspective as a practitioner's perspective, not as an evaluator's perspective. First things first, right now the budget that we are spending on health is huge. So I would exactly tell you where the problem lies. There are two departments. Health department was bifurcated in 2015 December. Just for a simple reason that there was absolutely little or no attention that was given to primary and secondary healthcare, and all the resources and all the attention was being given to tertiary healthcare. So that was the reason that the health department was bifurcated into two. And the first budget that was given to health department back in 2015 December was 46 billion on development and non-development current side to run almost 3,000 health facilities in Punjab. But as we speak now, right now, the budget of primary and secondary healthcare department is 184 billion rupees. And if we combine the budget of health department of Punjab, which is tertiary care and primary and secondary care, is a whooping amount of 470 billion rupees. So where the problem lies? I would, I am saying it from a position of authority right now, that the political determination to actually provide health insurance to 100% population of Punjab, I'm talking about my province right now, has stipulated annual health spending budget with less productivity. Now, this is very important. It is a strategy that may lead to have great political dividends in a short term, but it's a very faulty approach in the long run for overall health uplifting. Madam talked about India, but I would talk about China. China is a parallel superpower, actually an economic superpower. We hear of America defaulting these days, but we do not hear the same about China. China started their spree of financing health in 2009. And if we speak of China right now in 2023, 90% of their rural population is covered for UHI, Universal Health Insurance or Universal Health Coverage, and just 65% of urban population. There is absolutely no nation who can cover the whole population whatsoever. So we have to spend, because there are 3 types of financing. Right now where I'm sitting, I have to disburse 184 billion rupees budget. So one is out of pocket expenditure. I have to see that too, that 70 to 80% of population who cannot afford the private sector consultations, or on the curative side, they cannot spend much. I have to cater to them as well. Then there is that conventional mode of health financing. So what we do is here, and I would request all of you who are not from the government side, I think I'm the only one on the platform from the government side, to profess this thing, to advocate this thing to the people at the right platforms, that political governments come and go, but the preferences should be the same. Our approach is always inverted pyramid approach. 70 to 80% population of Pakistan and Punjab deserves to have a financing on the preventive side right now. And only there are 10 to 15% of population who require the tertiary care interventions. But we have the inverted pyramid approach. We are giving 70 to 80% of the finance to the curative side and only 10 to 15 on the preventive side. So that is the reason that we are catering to the ailing population. On the tertiary side, we bring them to the urban centers, treat them well, and we are sending them back to the environment where they get in. And this is a vicious circle that is going on and on. And then I would tell you one thing: we are the second largest nation with the largest burden of hepatitis C. If I talk about Punjab, and I'll tell you that these figures are so updated because we just hosted on Saturday the joint evaluation, external evaluation team of international health regulations of WHO, who is visiting Pakistan and all the 4 provinces for their final report of WHO. They visit all the nations, all the countries, and then they come up with their report. So all these figures are updated. Total registrations in 5 years of hepatitis, I'm just giving you one case study of hepatitis, is almost 3 million. Punjab has registered in 5 years 3 million cases of hepatitis. From them, 5 lakh are hepatitis C and hepatitis B are 1 lakh. Right now, we have vaccinated almost 2.2 million. If I talk about the budget, there is almost 3 billion that in this current financial year we have spent on hepatitis. But then again, I would come to my earlier point that the prevalence of hepatitis, the prevalence of disease burden such as TB, NCDs, as Madam talked about, diabetes and other such diseases, this can be lessened. This is absolutely no issue. In 5 years, Punjab, if I talk about Punjab, just in 5 years, Punjab can be the healthiest province of Pakistan if we do not add a single brick in the system. And I would just I would just humbly disagree with this idea as well, that there was infrastructure improvement when the universal health coverage in the previous government came. Because we have right now, if I tell you, we have 26 district headquarter hospitals in Punjab. We have 126 Tehsil headquarters in Punjab. We have 324 rural health centers in Punjab. This is very important. And we have 2,500 basic health units in Punjab and just 45 tertiary care hospitals. There is not a single brick that is added to the system. Yes. In the previous government, some mother and child hospitals worth rupees 30 billion were started. And right now, government is thinking to convert them into general hospitals. They are not functional right now. They have a grey structure and all. But we, just on the pretext and just on account of preventive healthcare, In the previous 4 to 5 years, we were spending that money on the infrastructure. That is the reason that hepatitis prevalence has increased. That is the reason that TB prevalence has increased. I have HIV numbers with me as well, but just because the data is confidential, we have shared that with WHO. But when we are not giving the medicines, when there is, and one more thing, let me burst the myth as well. There is never a shortage of medicine. If Punjab is spending 15 billion on the medicines alone, it is just that when we are diverting that to the development expenditure, and that is adding bricks and infrastructure, bricks to the system, and we have already almost 3,500 health facilities. If we are not revamping them, if we are not giving them people to their doorstep, this is what we call universal health insurance is not giving the people health service delivery to their doorstep. It is making a BHU 24/7. It is the skilled work attendants that have to be there. And one more thing, Madam talked about electronic medical records. Right now, and I would suggest that a team of Karandaaz should definitely visit primary and secondary healthcare department as well. In Pakistan, this is going to be, and this has become the only department that is going on to the EMR, which is electronic medical record, to the BHU level. Madam, if you go to any BHU, basic health unit, you can just pick up their tab and you can see that how many children were immunized today, how many deliveries in last 7 days, what medicine was given to a child, whether the vitals were taken of a child and of a lactating or pregnant woman or not. This has been floated in almost 2,000 BHUs in last month.
I believe we've lost Ms. Fatma. Ms. Fatma, can you hear us?
And it is being rolled out to all the provinces as well. Well, to cut the long story short, I would just reiterate the fact that primary and secondary healthcare in Punjab, I am not talking about Pakistan again, in Punjab is catering to 13 million patients in OPD. If you talk about basic health unit, the footfall is footfall is almost 12 million in 1 month. In 1 month, people who come for flu, cough, diarrhea, and all that. One more thing, there is a rural ambulance service that again is on the preventive side, and I'm talking about the children. The children with diarrhea, with malnutrition, they are picked up from home. They are brought to the primary healthcare facilities. If they have to be referred, they're referred to the secondary healthcare facilities, and if not, then the tertiary healthcare facilities. So my last point would be that the spending, there is absolutely no dearth of doctors and nurses as well. In our system right now, there are 15,000 doctors and there are 9,000 nurses. And in a country like Pakistan, I think if 3 beds per doctor or 2 beds per nurses is the ratio, it's not a bad ratio. It's just the right approach of things. We have to go into the phased manner. Putting 127 billion into the universal health insurance and not spending much on the preventive side is the real issue. Right now, Punjab, for the budget 2023-24, the next financial year, we are almost spending 20 billion on the preventive side, and we are hoping that things get better. And that's all from my side. And if there would be any questions, I would be happy to answer. Thank you so much.
Thank you, Ms. Fatma. We will be moving on for now to the presentation, but if anybody has any questions throughout this webinar, please leave them in. I think Dr. Shamshad has a question.
Yes.
Yes, Doctor.
I'd like to compliment Fatma for presenting such a realistic feedback on what's going on. And I 100% agree with a lot of things she has said, particularly on wasting money in the health sector through provision of assured services, funding that they have been doing. And I can tell you from my international experiences, I believed in conditional cash transfers of a specific type, but in a very controlled environment. I don't even believe in unconditional cash transfers. And particularly, I think it's often very misrepresented by donors that we are doing such a great job in terms of the transfer of this particular scheme and that particular scheme. And I 100% agree with your point that we should not politicize our sectors or our country. And we should really have a consistent program chalked out for the reform, which has a buy-in from all the stakeholders, and we should stick to that. So I very much value your remarks, and I congratulate our team for bringing you to the table, not only because you are a women leader there, but a person who has spoken from the heart and real experience. And I think, Vikas, we need to really rope into other provincial departments too, because as I also said, provinces are really steering this, and they are facing difficulty, but I think such dialogue will bring us to reality as well as bring us closer to these departments for going forward. So Vikas, I tremendously appreciate your leadership on this. Thank you. Sorry to intervene. I usually don't.
Thank you so much.
Thank you, Chair. Thank you very much. Fully noted. This was the idea that when we are organizing, we should be talking to the people who are in the trenches and know exactly what is happening. And obviously, our role is when it comes to additionality, where public sector or even the private sector is not doing, what is that, how we can help the areas that we can invest in. So Fatma has very eloquently presented that. I'll convey to your secretary too as well. Thank you very much for being here. I just wanted to ask you a very quick question. Are there any areas that you think if private sector investment can go in very quickly? I mean, you know, from the top of your head, it can be diagnostic, it can be high-level specialty care or anything else. Are there any areas which come to your mind very quickly where impact investors like us can go?
Sir, I would just tell you that there are very good laboratories that in 2007 and 2018, when Mr. Ali Jan Khan was the secretary, I do not call him a bureaucrat, he's a reformist. So actually he wrote the DNA of his department. He has come back as a secretary again. So what he did was that in some of the district headquarter hospitals, he outsourced the pathological services. So IDK and a couple of more labs came forward, and they joined hands, and the services were given through there. And then there are 5 or 6 hospitals in government of Punjab that are being run by one of the, I don't know whether I can name them or not, but there is one of the what should I say? It is one of a trust that is running. So government of Punjab is giving them grant and aid, and they are running the operations, and they are running the operations in a very good manner. So there are almost 5 hospitals of primary and secondary healthcare departments, a very big blood bank of tertiary healthcare, and 2 tertiary healthcare hospitals, which are being run by a private trust. So yes, these type of interventions, yes. And there were a lot of interventions back in 2017 and 18 when our pathological services were outsourced to private labs.
Thank you, Fatma. Thank you very much.
I think it's time for us to move to the presentation. Unfortunately, we're running just behind schedule, so there might not be time to take too many questions, but please put your questions down in the Q&A section, and we will try and answer some of them towards the end. And now I would like to invite Imran Zia, who was a technical lead for the study, along with Behzad Taimur and Ms. Meher Shah for the presentation. A brief introduction of all of them. Imran Zia heads SERP's Analytics, where he helps private and public sector businesses and enterprises using data-driven and evidence-based analytic frameworks. Behzad Taimur is currently program manager at SERP Analytics. He is an experienced development sector professional who specializes in research, development, knowledge management, and grants administration. And lastly, we have Meher Shah, who has enough experience working in a wide range of local, regional, and global development agendas. She is currently leading Karandaaz's research, insights, and marketing communications portfolio. Over to you guys. Behzad, if you can share your screen, and guys can start with the presentation.
Assalamu alaikum to everyone, and welcome to the launch on the private sector healthcare services delivery in Pakistan study. Now, as Dr. Shamshad as well as Waqas mentioned in great detail, healthcare is one of the key sectors for Karandaaz investments. To elaborate on that a little bit, I would like to say that this does not just include small and medium hospitals, but it also includes supporting services such as nursing schools, diagnostic facilities, primary care, the pharma industry, and innovations in delivery channels such as telehealth platforms. So we continue to look for opportunities, and I would specifically like to share this with all the participants. Currently, Karandaaz is 8% of Karandaaz's total investment portfolio is invested in the health sector. So these are some of our own statistics, and this led us to conduct this study. This is the largest ever private sector healthcare assessment that has been done in Pakistan. And I will, Behzad, can we go on to the next slide, please? I will not delve into too many of the details. Next slide, please. I will not delve into too many details on this slide, given that we're running about 20-25 minutes behind time, but we can see that over time, Pakistan's performance on key statistics in the health sector has been pretty stagnant, and as compared to world standards, Pakistan lags behind significantly in its healthcare sector. So these are reasons which have motivated Karandaaz to continue looking at the health sector as a key space for investment. Next slide, please. So how did we approach this study? It is really divided into 3 different segments. The first was we wanted to landscape the private healthcare market in Pakistan, which meant looking at the demand side as well as the supply side. The second aspect was to look at investment and innovation. So what were innovations that were happening in the health sector, and then looking at it from an investment perspective, specifically to inform our own investments, and also looking at other financing entities which may be interested in health as an option for investment. And ultimately, we've got a set of recommendations, and these are also segregated by stakeholders. So, what can investors do? What can donors do? What can other policymakers do? So, all that is laid out. Next slide, please. Now, the way this was approached, it was a very, very expansive study. Like I said, we looked at the demand side as well as the supply side. On the supply side, we profiled about 289 private hospitals across 16 cities in Pakistan. In addition to that, approximately 1,100 consumers of health services were also interviewed across these cities. And then finally, we conducted about, the SERP team conducted about 58 qualitative interviews, and this included key stakeholders from the investment space, from the innovation space, as well as administrators of hospitals. Next slide, please. Okay, right up front, I would like to say that, there are some aspects of the health sector which this study did not cover. Of course, a major aspect is the public sector. So, an area covered by the study. Sorry, Behzad, were you saying something?
No, please continue.
So, yeah, the public sector was not covered. In addition to that, we did not go into small cities. By small cities, we mean those cities which had a population of less than 500,000, and small hospitals which had a capacity of less than 25 hospital beds. Rural areas, of course, were not covered. Then the much smaller private clinics were not covered. And finally, mental health care in this study was not covered. So the findings are extremely interesting, and I will hand over to the SERP team here to share some of those. Thank you. Ji, over to you, Behzad.
Thank you very much. जी तारफ हो चुका है behzad तैमूर, प्रोग्राम मैनेजर SERP, इस स्टडी को प्लान इम्प्लीमेंट कामयाबी से एग्जीक्यूट किया और उसके बाद we did data analysis, or I played a significant role in putting together the key insights in the final report that is now available as well. What I'm going to do henceforward essentially is to walk people through some key and interesting insights that we have gleaned through this Pakistan-wide study. Please remember a couple of things. All the stats and the observations I will be sharing with people are at the Pakistan level. If at any point in time I need to get into a more specific province or a city level observation, I will qualify it as such. Everything else should be seen as a Pakistan-wide perspective. We are talking very high-level insights. Guzarish rahegi ki we are trying to share some cheetah, moti insights, details to everything are available in the larger report. With that said, I will jump into this. जैसे कि पहले आपके हजूर गुजारिश की जा चुकी है कि this was a very wide-ranging, nuanced, multifaceted study. We looked at multiple things. We have now, for this presentation, broken down at least some of our findings into key buckets, and I'll be starting with the first one, which essentially is demand versus supply. When we say demand, what we mean is demand coming from the market, consumers of health services, mamlakat-e khudadad ke jo shehri hain, wo kis tarah se dekh rahe hain, versus supply from the hospital and healthcare service providers. So the first observation I would like to submit would be that we now have data that shows that there is a very significant misalignment between the market and the provision of healthcare services. And if you allow, I will momentarily jump to this. So, agar aapni screen par dekhiega, there are a few columns for you guys to look at. The first column to your left essentially shows when you ask people what is the most common disease that you have to contend with, what do they report, organized by the highest reported disease going further down. The second column on the screen to your left, we actually ask hospital administrations to let us know what they thought were the most common diseases that they were trying to deal with, right? And then the next column shows availability of specialists and, of course, facilities at the hospitals. What I've done for this presentation is that I've highlighted the top row for you, which is the number one listing, either given by the consumers of healthcare services or hospital administrations. Just to point out very briefly, when you ask the citizen of the country, what is the most common disease that you contend with, they're reporting diabetes. That is number one. But when you switch to the next column, you would say when you ask the hospital administrations, they're reporting gynecological issues. And then that is how it continues, go forward to the facilities, ultrasound. Ultrasound ki jo machinery that is not generally used for treatment of diabetes. So the hospital administrations have a very different view of what they're contending with and how to deal with it. People are saying diabetes. And if you go farther down any of the columns and compare with any of the other metrics, you should be able to see okay, there is a misalignment between what the people think are the big problems they're dealing with and how the hospital administrations are trying to address it. With that view set, I'll jump to the next point. Again, we have data now that now shows that provision of healthcare services in Pakistan is three things. It's unwholesome, it's incomprehensive, and it is geographically in particular dispersed. What that means essentially is to treat the same disease, all the sort of facilities or services that you require are hardly ever available in the same facility. So for example, agar hum dil ki bimari ko dekhiega, so you might have a cardiologist,
But for escalated cases, there would not be a cardiac surgeon in the same hospital. To get a surgery done, you need to go to another facility. Incomprehensive है किसी एक भी फैकल्टी की सारी के सारी सर्विसेज मौजूद नहीं है, जैसे कि मिसाल दी मैंने आपको कि जी फॉर एग्जांपल कंसल्टेंट्स फॉर कार्डियोलॉजिकल प्रॉब्लम्स आर देयर बट सर्जरी इज नॉट हैपनिंग, राइट? Surgery के लिए you need to go elsewhere. The most common example is you go see a doctor at a hospital, they prescribe you tests, which you then need to go outside the facility to a private lab and get the test and go back to the hospital and show the reports to the doctor. That shows the incomprehensive provision of services there. And finally, it's also dispersed. And if you allow, I will jump to this very nice looking sort of projection that I've created for you. So what we've done on these two graph for you is around the circle are the 16 cities that we have profiled essentially. और आपको साथ-साथ की मौजूद है, there is family medicine, for example, the surgery, gynecologists and so forth. That is the doctors, specialist doctors available in the right one. You can see facilities being available. What you can essentially do to quickly read this is to follow any color that you prefer. You can pick blue, green, and so forth, and just go around the circle. You'll see different cities. Wherever a line is touching the circumference of the circle, that should suggest to you that ये relevant doctor या facility इस शहर के अंदर is adequately provided. Wherever there is a cave or a sort of like a valley, right? That means that उस वाली चीज की provision is not available. So looking at it, look, you can pick, for example, Karachi. Karachi stands out. Specialist doctors का अगर आप left वाला देखिएगा तो there is no line that is actually touching the circumference. Everything is a cave or a valley falling in. That shows that provision of these types of medical services is absolutely inadequate in, for example, Karachi. So with that sort of observation reported, it should appear to be following naturally. If, for example, अगर ये facilities or doctors available ही नहीं है, so people should be traveling to other cities to acquire the health service they require, right? So actually our data shows that travel for health within Pakistan is actually counterintuitive. It's not happening. Less than 4% of the people that we actually surveyed had actually visited another city to acquire health services. Our data also now shows that people, about 70+% of the people don't even prefer to go outside of their own neighborhood that they're living in. And why is that so? Very simply, 270 plus ka agar liter petrol mil raha hai, so you can be reasonably sure that travel has become very difficult at the current moment in time. So continuing from the same thread, we did explore the questions of pricing and affordability of the private healthcare market in Pakistan. So if you look at the first point that I presented here, the observation there is that healthcare tends to be excessively expensive. And how expensive? Let me show you this. You can pick and choose metrics that you prefer, but I have marked in red at least one line. This is the average amount people paid for a general surgery the last time they or somebody close to them had to pay for his surgery. Agar aap Pakistan-wide level dekhiye, the first column with figures, 43,000 plus rupees is the national average that people are paying for just a general surgery. This is happening in a context where the average household, and please note, household in Pakistan, a household average is 6 persons. So 6 logon ka kumba collectively 42,000 a month kamata hai. So just one surgery is 43, which is more than the household total income. That is how expensive this is. Abhi हमने देखा कि costing किस तरह से dispersed है over different things, surely, but cost tends to be similar. That is a big observation for everybody in the market. Everybody is supposed to pay something around 40,000 for a general surgery, for example, but people tend to have different incomes. So that is the second observation. I'm jumping now to this. So SEC brackets, जो है इस पे हमने breakdown किया हुआ अपना data that shows A1 is the richest, the elite, A2 is the upper class, B would be upper middle, C would be middle class, and going downwards, E1, E2 is the bottom quintile of the society. So I've marked in red, agar aap first wala column dekhiega. So A1, the last time they visited a hospital for any purpose, paid about, on average, 14,000 rupees. C, the middle class, also paid 14,500 rupees in the last visit that they made to a hospital. And E2, the bilkul bottom of the society, also paid 14,000. The observation here is cost of healthcare is similar for everybody in a context where different people are earning different amounts of money. So that means jin sahab ki, for example, mahana tankhwa 1 lakh rupees, wo jab 15,000 rupees pay karega hospital mein jaakar, that is 15% of that gentleman's monthly income. Whereas somebody is 10 lakh tankhwa hai, jab wo 15,000 rupees pay kare, to uske liye 1.5%. So different groups in the society are paying different amounts of money. And why is that such a big problem? Because now data shows 64% of the people are paying out of their own pocket. Cash-driven economy, cash-based economy purely. So you have to dip into the money that you have available. And about 20 or so percent thereabouts are taking loans, again, cash instruments. Our data shows just 3% of the people, just 3% of people have private health insurance. And most of these people tend to be working in the corporate sector. Something of the sort, but the company is paying for your health insurance. Though about 13% people now are beginning to use the Sehat Sahulat program. So that is also micro health insurance. So the market trends are changing. People are moving off of now their out-of-pocket payment mechanisms. Speaking of Sehat Sahulat, we looked into Sehat Sahulat program as well. Some good news around the house. About half the people that we talked to knew about the program. कोई समझ होनी चाहिए कि खैबर पख्तूनख्वा पंजाब के अंदर deployed SSP, southern half of the country, Balochistan के अंदर SSP does not exist at the current moment in time. So that checks out. 24% of the people we talked to had used it. So was the usage experience great? Actually, data says yes. 70% actually found it very easy to find a panel hospital. So SSP is paying a hospital. You go to the hospital to service. 70% say it's easy to find it, which is great news. They got their marketing and targeting right. 92% of the people actually stated that when they used SSP, they had a great experience, which is good news. Around the house, how good was it? We even explored that a bit. So let me jump to this very quickly. 79% of the people who use Sehat Sahulat program are saying that they managed to receive exactly the same sort of care that they otherwise would have received if they were not on the SSP. वो खुद जाकर payment कर रहे. 13% had a bad experience, but interestingly, 8% of the people that we talked to who were on the SSP actually managed to get better services from the same private hospitals than otherwise they would have. With that sort of said, this is my favorite graph tends to be. This is showing the last time you went to hospital, how much money did you pay versus the right graph that is showing you long-term disease management, for example, diabetes, kidney disease, heart disease, ये long-term होती है. इनको treat करने के लिए आपकी spending कितनी है on a monthly basis. So the blue dots would show कितनी spending है अगर आप Sehat Sahulat program में enrolled नहीं है, उसको भी इस्तेमाल नहीं करें. Versus the red dots, that is the spending that is happening from in those buckets में people who are using the Sehat Sahulat. Good news around the house, you can see huge jumps across the board. Especially if you look at the bottom E1 and E2 on the right wala, जहाँ पर long-term disease management is the big thing being shown. Look at the jumps. Blue dots के ऊपर जो jump है red का, that is showing how much spending has escalated. People are using SSP to acquire health services, and hopefully that's contributing to improvement in health outcomes as well. Not everything is good. Overall, there's perspective that's emerged with the Sehat Sahulat program. Some things we've noted here, for example, procedures like surgeries are covered by SSP, but consultations are not. So visiting a doctor and seeing a doctor is not covered by SSP. That forms a large chunk of healthcare services. The acquisition that is not covered. Entire verticals of disease, a single disease, is not covered. Procedures are covered, surgical treatment is covered, but if you need any other diagnostic, so forth, associated services, that is not covered. This is a concern. And finally, this is coming largely from private hospitals. They're saying the money that they're getting from SSP to dish out, to disperse these treatments and perform procedures, they're saying it's not good enough. It does not really help them meet the cost that the hospital need to incur. And this escalates as you go from rural areas to urban areas, more urban regions have higher cost overall, and the hospitals particularly that cater to slightly better paying clientele really note that this is not working out for them. In the interest of time, I'll just jump through a couple stats. We explored tech and innovation. Good news there. Smartphone ownership seems to be growing, in particular, female ownership of so smartphone, not dumb phones, not button phones, touch screens, and internet enablement, that sort of thing. Very quickly, I can show you this. At least one concern has been that women don't own smartphones in our survey. This is purely based on our survey sample. We can see particularly Punjab, 76% of the women we interviewed owned a smartphone. Sindh mein 81, which is actually more than even the men. More women in Sindh own smartphones than men do. Apparently, that's emerging. KP tends to be a little, behind on that front, but half of the women there also own smartphones. So many smartphones. What are they doing? We explored that. Usage tends to be still entertainment. What do? People are basically watching videos, doing TikTok, that sort of thing. We did ask them, do you use a smartphone to buy services, anything online? About 45%, half the market, has begun to use smartphones to make purchases online. So we also explored how are they doing this stuff. And our data now shows that people are beginning to pay online for the things that they buy online. Men do it, surely, but our observation here is if you look at the lighter colored graphs, particularly Punjab and Sindh, well, KP2, but these two in particular, you would see women who buy online also pay online much more than men do. So apparently, smartphone owning women is a great market to look into. And this is not a gender issue only, in the sense if you look at the different socioeconomic classes, look at the 40% line going across, broadly the average is similar. The richer folks are better educated and they have better access. Of course, they're paying more, but the lower classes are also 39% for D, right? They're paying online. What do we mean by online? Generally, we mean Easy Pesa or Jazz Cash. So for at least the observation there becomes, if you have a tech sort of intervention coming, at least integrate these two with it. Or the more popular ones tend to be Marham and so forth. We are running very low on time. Imran, do you want to jump in? I can run through just a couple of points and then you can take it from there.
Yeah, you can take 30 seconds to go through this very quickly and then I'll start my portion.
Right. Surely. I'll just focus on two of these. Most of the stuff is written out, available in the report. Please go ahead and read that and it'll be very interesting for you. In a country where the population now is 250 million thereabouts, we have seen hospitals are few and far between. Yet we have done this analysis. Here's something to look at. If you simply look at the inputs, which means doctors and nurses, hospital beds, and do efficiency analysis against outputs, treatment, people admitted, bed occupancy, that sort of thing, we now observe that the mean or the average nationwide current installed capacity of hospitals that are already built in are operating at about 71% efficiency. That means 29% of the installed capacity is lying vacant. The biggest city to look at is number one on the screen, Peshawar. Hospitals in Peshawar are operating at 33% efficiency. Look at that, 2/3 of the installed capacity is not even being utilized. If you simply bridge this gap, begin to bring online the installed capacity, you could be sure at least some difference would emerge within the market. And finally, I'll just show you this. If you look at the pie chart to the left, this is across Pakistan, nearly 88% of the market, private hospitals, have one single owner. So no corporate boards, nothing. This is a private sort of enterprise. People are running the whole show like a lifestyle venture, right? The basic motivation people usually have is to go from the Cultus that they own to the Corolla, and that's about it. Multiple owners is just 12% of the market. And that means 2 and above, this could be 3-4 brothers running one facility. That suggests there is very little corporatization, corporate boards and so forth, not there in the market. And that creates significant challenges, especially in terms of growing the sector by inviting investment into it. because the family-run enterprises, so virasat ki masle masail darpesh rehte hain, and people are not willing to talk to investors and accept infusion of capital. And all of this is happening to close this off in an environment that is politically unstable, financially on the down, and economically just topsy-turvy overall. I'll stop here. Might I call upon my colleague Imran Saab to take it forward?
Thank you, Behzad. I think there's tons of data that we collected, and I guess we could talk endlessly about what we found out, and some of that is our great insights. Thank you, Behzad. Let's flip to the next slide. I will go through some recommendations and possible next steps. The next slide, please. So essentially, first of all, there are three main buckets. After we crunched all the data and looked at all the possibilities, there are three broad set of interventions that we propose. On your leftmost is healthcare service provision. How do we improve that for better health outcomes? Our first recommendation is that we should build specialist small, medium brick and mortar facilities in B cities. Cities means non-capital cities in Pakistan, and smaller cities that exclude cities like Lahore, Karachi, Quetta, Peshawar, etc. And the idea there is that based on the disease pattern in a particular area, you put in maybe a nephrology hospital or a cardiovascular disease hospital in a particular area. And the way you enable that is that the best way to do that would be to perhaps entice an existing large hospital in a big city to open up smaller hospitals in other cities where there is a need. Because obviously, then there is a transfer of knowledge. And then there can be more complicated cases could also be transferred to the larger city, to the larger hospital in the large city. The second recommendation that we have is to create a primary care referral network. Primary care is fairly bad from what we could see in the smaller cities, and to enable that. If there is a tech-enabled, and there's a lot that's going on in this recommendation. So what this really means is that, number one, you focus on primary care. You create these facilities or hospitals or small hospitals which cater to primary care, but then primary care is not profitable because there are no procedures involved. It's mostly advisory, and your consultant is going to keep 70% of the revenue. So the hospital does not get much out of that. So what you do is you tie it with at least one or more specialties. For example, you tie maybe a cardiovascular facility with such a primary care hospital, so that it becomes actually profitable. And what does the tech-enabled piece do? The tech-enabled piece does is that it actually connects this hospital to larger hospital networks in the same city as well as other cities. So because nobody's going to come to this hospital for this just one, if it's a cardiovascular, which is its specialty in addition to primary, then what if you need a nephrologist? Okay, I can use technology to refer this patient to another hospital, and I can track the journey of this patient all the way through, when they go to another hospital. And I'll talk a little bit more about it in the next slide. Number three is investment in management skills. Behzad just talked about the fact that 88% of hospitals that we surveyed are single owned. So the management as well as the care is not a separate function in many of these hospitals. So they're not professionally run. So you need to invest in improving the management skills of the staff that is running the operations at hospitals and hospital facilities. And then finally, if you look at the ratio, Pakistan has one of the lowest ratios of paramedical staff. I think the number of nurses that we have and the paramedical staff that we have is about 1/8 of the global average. I mean, that would tell you something about the severity of how less. And what that does is that how less of the staff is available, and what that does is that it puts a lot of pressure on junior doctors. Instead of they doing their job, they actually end up doing a lot of work of what the paramedical staff would be doing. For example, injectables and giving injectables to the patients and things like that. I'll come to the second bucket, which is the middle one, which is healthcare services. And the idea is that what are the support services that you can provide to cut the cost to the consumer, and some of it is that bring the diagnostic centers closer to where the need is. So you need a larger network of diagnostic centers even in smaller cities. And secondly, things like being able to provide pharmaceutical at your doorstep, through improving logistics, through connecting and aggregating the demand for, say, pharmaceuticals through some sort of a technological intervention, which could be an app or whatever have you. And finally, the last bucket where we recommend a bunch of things is that, and this is deeply tied to some of the things that I just talked about, is to deploy tech and innovation to improve access to healthcare. And a couple of things that we recommend there is, for example, interoperable, transferable medical records. And something that I talked about, that if you want to have your primary referral network tech enabled, then there has to be a common digital language that needs to be understood across the healthcare system. And the way I tell a lot of people is that, for example, Karandaaz has invested in Rast, which is enabling and really fueling the growth of cash transfer and online payments. A similar approach could be taken in connecting all the different players and different nodes in your healthcare system. If you had a common language that these different systems could understand. We also recommend that to improve the deal pipeline, we should encourage hospitals, maybe through certain initiatives, encourage them to, number one, improve their quality standards, bring in professional management, also make them ready for example, investment roadshows, working with them, make sure that they have all the information that will be needed, for example, by an investor to come in and invest in a hospital. So we make recommendation in that space. And finally, we also believe that that in medtech and healthcare, entrepreneurs could be facilitated through incubation, acceleration, and pre-seed entrepreneurial support, because again, that's part of a healthy ecosystem where you nurture small ventures, take them to a level where they are ready for larger investments, from investors who are wanting to invest in the healthcare space. So we can flip to the next slide. Azad, if you can, yeah. So here I'm showing exactly the same slide that I showed before, but if you look at what's shown in yellowish golden color, a lot of what I'm advocating here is looking at this from a system approach, because one of the things that if you gather from what Behzad presented is that our problems are not simple. They are large systematic problems that need to be solved. So when we apply an intervention, we want to take an approach where we look at the system and see how one intervention can support another intervention, so that the most number of problems can be solved. So if for example, if we enable technology in order for technology where a patient which is referred by one hospital to another and their prescription is fulfilled by a service which delivers pharmaceuticals at their doorstep, and then one hospital accepts patient from another hospital seamlessly, and all their lab tests and whatever have you gets transferred over, so that you don't have to repeat these tests again and again. Then you need a common language that is understood by all these players, and that's why we recommend that there needs to be a transferable, interoperable medical records. So again, this is taking a very system approach. Next slide, please. So this is again talking about an impact pathway, and it's pretty much what I just said, that you want to connect all these nodes through some sort of a digital intervention and a language that's understood by different players. Next slide, please, in the interest of time. And I also want to advocate here that I think there are certain limitations that Meher had talked about, and I think there is further inquiry needed. For example, one analysis that needs to be done is that we have looked at the private healthcare space deeply, but then we need to layer it on top of public health system and see what the interaction is. For example, at least in our case, what we found out was that in private healthcare, there's lesser travel between cities when you don't have a service available in your city. But it also sounds very counterintuitive, but that might actually be compensated by perhaps hospitals that are run by the government, for example. So that kind of analysis needs to be done. We need to look at private clinics, which are totally unregulated, hundreds and thousands of them across the country. They probably could be incorporated in some sort of a primary care network if they were registered and were following at least some set of standards. Right now, it's a market that's not well documented at all, and something that needs to be looked at and see how they can be incorporated into a more formal network. And finally, we also want to be able to study the consumer behavior. At least we saw, again, it's a non-representative sample, but in our sample, we saw that there's a lot of adoption of mobile phone, and even we saw indication of mobile payments and mobile transactions. But again, it's a non-representative sample, and it needs to be expanded and see that in the context of healthcare, what the possibilities are, and how consumers could be induced even more to use digital services and online payments and consumption of digital healthcare services. So I think that's pretty much it. Next slide, please. I think that might be the last slide, and then I think we can, I don't know how much time we had, but we can go into a question and answer session at this point.
This is the last slide. The floor should be open for questions and answers if people are interested.
Yeah, and thank you for being patient with us. We took a little bit more time than we should have, but happy to. I don't know if you allow any questions.
Nidhi, thank you for that wonderful presentation. But unfortunately, we do have multiple questions, but we do not have time. We are way behind schedule. But we will leave our email address, and I believe it's information@karandaaz.com.pk. You can leave your questions there, and we'll try and get them to Behzad and Imran Saab or Meher, and we'll try and get them answered for you. Also, for those who are asking, I don't know about the presentation yet, but the report will be available on our website after this webinar. Thank you so much, Behzad and
Meher. Hassan over here to Imran Saab and Behzad, there are a lot of questions coming in the Q&A, so you may want to respond in written to some of those questions.
Yes, you're a panelist, so you guys can also do that. You can check the Q&A box below, and you can answer them by typing out your answers. But now I would like to ask the panelists for panel number 1 to please turn on your cameras, as well as our moderator. I'll be introducing you guys, and then I'll be handing over the mic to Ali. So our panel is titled Bridging the Infrastructure Gap Through Innovations. The session will be moderated by Mr. Ali Akbar, who is currently Senior Manager, Research and Insights at Karandaaz. He has been involved in various research studies and data gathering exercises in the domain of financial inclusion for SMEs and individuals in Pakistan. We have Mr. Furqan Kudwai, who is CEO of Dawai.pk. He is also the CEO. He is one of the pioneering digital entrepreneurs in Pakistan and the first in the digital healthcare space with a mission to make healthcare more accessible, affordable, and understandable for consumers. Previously, he was an investment banker for over 8 years in London and New York. We have Ms. Iman Khan, who is CEO of the Slosh AI Solutions. She is an electrical engineer by education, but after completing her MS in machine learning and image processing, she founded Slosh AI, a startup working on creating assistive AI tools for reading chest X-rays. And lastly, we have Dr. Sara Khurram, who is CEO of Sehat Kahani. She has over 8 years of experience in the field of digital healthcare as a co-founder and CEO of Sehat Kahani. Previously, she was training for a career in radiology and has also worked in micro health insurance and community healthcare initiatives with USAID. And with that, I would like to hand the mic to Ali to begin this session.
Thank you, and I welcome all the panelists. Good afternoon to you. Thank you for making the time to join this very important discussion. I will be grateful if you can keep your responses to 5 to 6 minutes, since we are running behind time. So without any further delay, I'll jump into the questions. Furqan, can we start with you? Your company, Dawai, started off 8 to 9 years ago as an online pharmacy in a highly fragmented and gray market. Today, the platform provides a whole host of services such as telemedicine, at-home nursing care, and mental health. Given that it has now become a major player in the health sector, what was this near-decade journey like? And can you explain how your customer base grew, considering our research shows that the incidence of using phones for online consultation is low and that people still prefer cash over online payments?
Great. Thank you, Ali. Fantastic report. I think some very credible insights of the much missing information out there in Pakistan. So kudos to Karandaaz for sponsoring that. Look, so Dawai started about 10 years ago almost now. And the journey, to cut it long, the long story short, was long and a steep learning curve as well for me personally, particularly coming as an outsider, not from a healthcare background. So, but that did give us an opportunity to actually look at it more holistically and more objectively, as opposed to being an insider. I think, look, I will cut the story into two pieces, right? So one is very specific about how two main sort of critical roadblocks which we faced earlier on, and which any company would face when it grows. One is, of course, I think building the supply side of things, having your partners support you, because especially if you're doing something very innovative, very out of the box, something very different, which hadn't been done. And mind you, now we're talking about this tech-enabled digital health, right? 10 years ago, this wasn't at all. And the smartphone prevalence wasn't as much as it is right now. So getting people to take you seriously from a pharmaceutical standpoint, from a supplier standpoint, was difficult, because what you were doing, even your family couldn't understand what you were doing. So that was something which took a lot of time for people to buy in and believe. Of course, one element was the storytelling side of things, and what the vision is and what you're trying to solve for. The other element is, of course, once they start seeing the economic value out of it, once the business grew. And that's again a catch-22, because the business wouldn't grow if you don't have the demand side of things, right? So the supply side was a long drawn process, and it's still something, a very steep learning curve for a lot of traditional market participants who we have to deal with and educate even today. On the consumer side of things, with the patient side of things, that's another journey. That's because in a healthcare space, you can't really go and market your way up. It's just a matter of time. We have Sarah here. She can talk about from the longevity standpoint. It is just a matter of being there for people, accepting the fact that you are a genuine, serious player who can actually provide healthcare, because it is different to buying pizza. Coming for healthcare, coming to get your medicines, coming to get something, you're basically going to see a doctor who tells you what to take. You have to trust that. So the element of trust takes time to build. There is no sweet pill for that to be get around by, whether by throwing money or by any other way. It just takes time. So one of the key things we did on building the trust, one, of course, the longevity is 8-9 years. That's nothing can go away for that, right? And there's no way around it. The other thing was we started writing a lot of content on the platform about basically telling information around how to take drugs, basically. Now the question is out there, how many people actually read that content? I don't know. What it did do, was to add a lot of credibility for people searching online for certain ailments, which is of course happening. There is tailwind behind people trying to Google their way out, right? Even doctors, if you speak to, they would complain that people come and there are more doctors than we are, because they read something on Google and they challenge you out. So that element, I think, worked in our benefit. It was something, a bet which we took. Can we actually give all the information which a pharmacist normally gives in the more developed world about how to take medicines, when to take medicines, and so on and so forth. For example, an iron supplement should not be taken with water. I did not know that until I got into this business, right? So that's something, if you go to a pharmacy in a developed world, he would tell you or she would tell you to take it with milk because it would oxidize otherwise, right? And will lead you to certain digestive system issues. So that sort of information we started sort of putting it out there publicly. Then the second thing we did was, I think that's the report is missing around. There's a stark difference in the pricing between the branded drugs and the generics available. Of course, Pakistan is a branded generic market. It's not a brands and generic. It's a brands and branded generics, right? But doing a price comparison based on the salt composition was something else we did. It was just an interest of making a directory and putting out there with the content. That's as simple as that. That's a bet we took about 7 years ago and invested heavily into that. That paid off sort of, I think, dividends over the years, where everyone was just searching something online. We had content, so that kind of married together, and our sort of organic user base grew significantly. And that also tied in with the trust element, where people searching for certain things, they would land onto the page. Most of them would just take the information and go, which is fine. But that trust element, whenever they needed to get something, they would actually come because you effectively are there as an information provider, which is legit and which seems legit to begin. Of course, I'm going to say it's legit, but seems legit from a user's perspective. So that's how essentially the journey actually grew, where consumer base continued to grow. And then the supplier side, of course, over time, and still today, that's a work in progress, that kind of married together over the years, right? So it's about 21 million users we have on the platform, which is grows. There's actually zero marketing spent to get that user base, but they come on the platform, they take information, and they go away. Some of them, a small portion of them, actually transact, whether to buy medicines, whether to take telehealth, whether to get the lab test book, nursing, whatever. So that's how actually the journey of the why has been. But I do have a point, because I think there were a couple of times mentioned during the previous presentation about the health system being broken and tech enablement is going to really, you see, I think one of the critical elements is that tech enablement is means to an end. Most people take tech as the end, right? Tech is never an end. Tech will be there to make your healthcare system more efficient. Tech will be here to make your health system more accessible, right? Tech will be there to actually make the system participants, not the patient side of things, somehow interact a bit more seamlessly if they do. But those are all secondary issues. Right now, the issue in Pakistan, in my opinion, is more along the lines of accessibility. That's one thing. Of course, there is no primary care, there's no urgent care, there's no, most of the people who can afford even a slight bit, so lower middle class and middle class, they end up at ER at a renowned hospital. And even those are far and few. Karachi is an exception. Even then, Karachi, I think, is overpopulated for the infrastructure we have. Tech is, I think, the secondary, but more importantly, people can't afford. So what the work needs to be done is around how to make it affordable. I think that's the key. Now, of course, you can't underpay doctors, because underpaying doctors has led to what it has led to, people leaving the country. So I think you've got to pay people well, so the service providers remain in business, but also somehow find a way where actually people can afford that. And that, I think, is one thing where brains need to be put together. And also, more importantly, from an insurance perspective, I know that has been much talked about area. I think the law of large numbers in Pakistan, which is the only benefit we have, as illiterate, as uneducated the population is just large enough. There are 300 million people out there. The country to 50 million people or 300 million people. So based on the incidence rate of a large population, people need to take bets on how can we subsidize it. Quite similar to the Sehat Sahulat program or whatnot, but something done by the private sector. I think that is where the efforts need to be put into place. And the second question we need to also ask, whatever the healthcare system is, I think it was touched upon that most of them are single man owned hospitals and infrastructure. Healthcare essentially, and especially the infrastructure, the hospital side of the business, my read is that healthcare is essentially a real estate business in Pakistan, bar one or two systems out there who are trying to build systems generally, because people come in because it is not sexy to go and make small clinics, right? What general people like Sarah said, what they do, it's not something which a big capital guy will come and find that good, but that's a real work, because you're actually going and getting people from ground up to the system. You can't build a 1,000-bed facility, which is expensive, and expect people to come in, which mostly happens because then those capacities are usually 10% utilization rates happening. The guy who's a rent seeker effectively worrying that it's not paying back for the capex which is spent. So the next best thing is you rent that place out. And as a result, most of our healthcare facilities are real estate plays for people. If you really dig in deeper, they are real estate business. You rent those clinics out to doctors, and doctors essentially go and just do their own clinic. And when you rent it out, there's no system.
Sorry, just to jump in very quickly, our research also shows that most of these healthcare entrepreneurs expect the land to be subsidized, since health is an essential good. But what they would do with that subsidized land is make profit. So that it's lopsided like that.
I agree. I think unfortunately it's not just the health, right? If you look at any entrepreneur or industrial concern in the business or in the news, they start with what subsidies government is going to give us to run a business and I make money. That's a very absurd way to think. And unfortunately, that's how we think in Pakistan. That's why probably the reason for all this mess we are in. So I think healthcare systems are not there. We're far and few. And in my opinion, they start from ground zero. Something where you go into primary care and then you go up the level, right? Setting up a nephrology unit today will actually be a very significant loss-leading business unless it's done at a very small scale, because you will not have enough cases. We have seen incidents at our level where antibiotic courses are not taken in full. Doctor gives a 5-day course of antibiotic, people take 2 days of dose. The fever subsides and they walk away because they don't have enough disposable income to do so. Now, they don't know the repercussions of antibiotic resistance and superbug and whatnot, but they never complete the course. In fact, that's a big problem which WHO is tackling right now in emerging markets where antibiotic resistance is picking up. And we see that every now and then in our case as well. That's a primary data point we have. People taking half the doses. So imagine the disposable income on those sort of stuff. Now we expect the nephrology and the cardiology and the high-end things to be profitable. It's not going to be the case, right? So the way to start is primary care and then work up the value chain. But more importantly, have to find a way to actually keeping it up, yet being profitable for business rather than going to the government to ask for something.
Excellent. Thank you very much. Your points, the main points that you made, building trust, technology being a means to an end, not the goal itself, and focus on affordability. Those were very good points. So with that, I will turn to Ayman Khan. She is the CEO of Slosh AI. Slosh, like Dawai, is solving a very important infrastructural problem through technology by personnel to make preliminary assessments for radiologists. And that this will lead to decreasing the cost burden on patients and tackling the shortage of radiologists in the country. So filling a very important void like that. So Ayman, we understand that this prototype is being considered at several hospitals in the country. Can you discuss the regulatory angle of health tech with us? So since your solution affects a core medical process, what sort of regulatory support have you received from the government? And what are some of the areas where policy making could be more enabling and conducive to innovation such as yours?
Thank you so much for this opportunity, and thank you so much for inviting me, because I believe that radiology has long been recognized as one of the most vital components of the diagnostic process. And while working in AI for radiology in past 3 to 4 years, I know that there is so much opportunity in this field for any investor who is willing to get high returns in their investment, as well as for any innovator who's looking for innovative solutions in less tapped market. So basically, this whole thing started when I lost a very close family member in the fight of cancer. And with the research, I found out that for a population of 220 million, we only have 1,200 radiologists to cater with that load. So basically, Slosh AI solution started with the very basic thing, that is the chest X-rays. Basically, there are 30 million chest X-rays that are done in Pakistan each year, according to WHO. So basically, the support that we actually needed from government was the support for the data sets. We built everything from the very scratch. We did our best to build the solutions. We made different solutions for CT scans, for MRIs, for chest X-rays. We took them to the hospitals, and then we realized that there is this gap, that the diseases that are actually there in international data sets, they're not there in our data sets because of the environment, because of the factors, the biological factors, and all that. So what we did, that we started tapping different hospitals. We started meeting people, because we knew that we have built something which is very much needed. This is a thing that is like the need of the market right now. So what we did that we started meeting different radiologists, different doctors, and the good part was that when I started 3 years ago, there was very less awareness in these doctors. They knew very less about AI. But as I moved forward, when I used to meet any doctor, any radiologist, any cardiologist, anyone from any field, they didn't know what AI is. They didn't know what AI can do to assist them, to give them extra pair of eyes and to improve their workflows. So basically, this was a good thing that started happening, and we started getting regulatory approvals from different hospitals. We basically tapped different hospitals that were from the private sector. And we were able to like get different data sets. We were able to partner with different radiologists. We are still in the process of getting IRB approvals to some bigger hospitals, some bigger networks. And we had the opportunity to meet like the government personnel directly in AI policy making seminar that was held at the NIC. And we put on the table that this is something. What happens is that there are data sets. The data sets are available. They are willing to delete those data sets from their systems, and they're not willing to give those data sets to us just by anonymizing them. We don't need the patient's information. We know as a strong player in radiology, we do know the regulatory approvals and everything. What we need is that bunch and bulk of data sets that actually would be used to improve our models. More the data, more would be the accuracy, more it would be performing better in every city. For example, if we get data sets from Karachi, which we are getting right now, we're getting data sets from Islamabad, we're not getting any data sets from Lahore right now. So even there is, the disease is different in different parts of Pakistan. So basically, what my suggestion is, and I gave this suggestion in the AI policy making as well, is that there should be a regulatory framework from the government. They need to establish a very clear framework specifically addressing AI applications in radiology, histopathology, and anything that is related to health. This framework should define the requirements for validation, approval, and ongoing monitoring of AI algorithms used in medical. It should
if I may, does the government have the capacity in the first place to do regulations for AI, or is it an absence of willingness, or both?
Yes, basically, I met the president, the honorable president of Pakistan, twice. What happened is that when I first met him, and I met him twice, like 6 months apart. When I met him first, and when I met him second, he actually remembered what we were doing, and he brought in his wife, who is actually much more into like breast cancer. So basically, when we met, I told him that I met you 6 months ago, and I put this problem on the table, that we are lagging behind. We are very much lagging behind because of lack of availability of data sets. And you are actually deleting those data sets. You are wasting that data. If you hand me that data over after anonymizing it, I would be able to like move forward. And what he said was that we are thinking of looking into that. But after like a year, when I went to that AI policy making, we were dwelling in the same thing. So there is lack of willingness. That is why I tapped in the private market, because I think that private sector is much willing to invest in this, their time, their efforts, they're like anything that is needed from them, they are much willing to go ahead. And what they take in return is that they say that whenever these systems are built, then we would be willing to test them out and see how these systems are going to improve our workflows. This is actually what is happening with us, that we improve our algorithms on their data sets, and then they test it back. But this can happen like on massive scale in government hospitals if they are willing to collaborate, if they are willing to they're not willing to understand what this is. Some of the research labs, one of the research lab that we have partnered with, they actually go to different hospitals that are government hospitals, and they try to like build this connection, and they try to like tap this thing that we are doing this. If it would be very good if we start doing this on a massive scale. And what they get in return is that how much IP we are going to get, what is our share going to be in that. So basically they just like, they step back. in private sector, things are different. They know what we are dealing with. They know what how much investment return they're going to get if they're just going to like get 10% of the whole like revenue of this product. They won't be like barging that we need the whole IP or we need the 50% of the IP. They are much aware of what this whole thing is. So basically, this is one of the gap that I see there is, and there can be anything. There are many things that can be done, like data sharing and access, like policies for promoting data sharing and access, which are essential for development and validation of AI algorithms. They need to do that. Recently, the AI policy in which like the seminar returned, like there is an AI policy that has been made, but I believe that like implementing that policy is going to take a year or two. So in government sector, we are lagging behind. I must say that.
Excellent. Thank you, Eamon. So I'll quickly turn to Sara now. She's the CEO of Sehat Kahani. So Sara, Sehat Kahani has exploited a very unique opportunity in the market by connecting out of labor force doctor brides to patients in a virtual. And this offering is not only related to consultation services, but also includes access to diagnostics and pharmacy services. It also has a telehealth initiative with the Gilgit-Baltistan government against a fee paid by the government. So how is this arrangement different from the Sehat Sahulat program of universal state-led insurance? And what sort of impact can this have on affordability, given that Pakistan has one of the highest rates of out-of-pocket healthcare expenditure, and our research corroborates this? And there are health shocks that are responsible for throwing many families below the poverty line.
So thank you for having me today, and congratulations on the launch of the report as well. I was looking at the recommendations, and it is amazing to see that so many tech-related interventions were recommended, which is great for the future of healthcare in the country. So before I talk about the question that you've answered, I'll give you a little bit of brief about how Sehat Kahani functions, because it's very pertinent to understand that, to understand how that fits into the context of universal healthcare coverage, or with the Sehat Sahulat card, as you asked. So Sehat Kahani started as a telemedicine platform that connects, as you said, out of work female doctors, who are the largest majority of the medical workforce in Pakistan, almost 80%, and bring them back to work and connect them to patients in low-income areas using clinics in low-income areas. Now, we did not create any clinics from scratch. We used clinics that were already being run by nurses or community midwives or lady health visitors, which are abundant in number across Pakistan. Because, as you said, a lot of patients in the country pay out of pocket. And in our low-income communities, where patients do not have doctors to go to, where in BHUs doctors are not available, the next available resource that patients visit in these rural areas are these community clinics, where a nurse or a lady health visitor is sitting, and she will see the patient for everything and anything possible. She's supposed to see a patient for only family planning and birthing, but since there is no other resource available, she becomes a primary healthcare doctor. Now, in many ways, this is quackery, but this is a force in our healthcare system that cannot be taken out and replaced by anything else, because they are there in the community running their businesses for over 10 years or 12 years or 15 years. So what we did was we went to these lady health visitors and we said, great, you are doing family planning and birthing, do not do primary healthcare. We'll set up your clinic, we'll give you a software, we'll give you an internet, we'll give you electricity. So whenever a patient walks in, you connect the patient to an online female doctor. You do your birthing and family planning, but for all other primary care practices, connect them to a qualified doctor. And since we paid them, so we charged an amount at the clinics and we paid an amount to them also, they became incentivized to create clinics. And that's how Sehat Kahani started. But as we moved on in our journey, we realized that covering healthcare through telemedicine only in low-income areas will not create a larger impact in a country like Pakistan, where cell phone and smartphone penetration was increasing year by year. So in 2020, we also launched an app for the urban market, or the urban smartphone user, in which you can download the app and you can connect to a doctor yourself. Now, this doesn't require any intermediary or nurse. And a thing that we noticed that was happening to other apps in 2020, particularly healthcare apps, is patients were not paying for any online consultation, which is there in your report as well. that because a lot of patients do not have the financial payment mechanisms to pay for the consultation, at the consumer level, the apps were not working well. There were a few apps that got shut down that were providing telemedicine at that time. So we realized that where is the market that can pay for an online healthcare consultation? And along with launching a consumer channel, which runs today, we innovated and created a solution for the corporate market in Pakistan, which is we provided our service to the corporate partner or the corporate who's running and has employees and their families and their dependents. And just like insurance, we gave them on a retainer basis a telemedicine coverage for the entire year. Initially, we went through the corporate and then we went through the insurance company. And we realized at that point, after running this model for 1 year, that this becomes a very genuine business case for the corporate, the insurance company, and a great value-add services for the employee and their family. Because the insurance company saves their claims, the corporate saves their premium, and the employee gets free of cost service, which is funded by their employer. So now Sehat Kahani works with 5 major insurance companies in Pakistan. We provide our services to 700 more corporates. And as we provided services to corporates, that unleashed so many other verticals and venues to expand the application. Something very interesting we realize, and that connects to your question, is when people take loan in this country from microfinance institutions such as Ahuad or UBank or Microfinance, Moblink Microfinance Bank, majority of the times, this loan is spent in a health catastrophe rather than exploring new opportunities to create a home or a business or making a livelihood or education. This is a massive problem for low-income families that pushes them in poverty with one single episode. So as we built our corporate portfolio, we realized that another type of institution that would really benefit from our corporate product are microfinance loans. And that's when we started to partner with Ahuad, with Moblink Microfinance Bank, with UBank, to provide our telemedicine coverage to people who take a loan from these organizations so that if they have a problem, they can start consulting on the app with the doctor rather than waiting for it to convert into a tertiary care issue and then go to a hospital, get admitted, and spend all that money that they take for a loan in a health catastrophe. So I'm just trying to explain you how a telemedicine solution can be tweaked to be used in different ways, to be used by different consumers, even if payment is a problem, which is a big part in your report. Now, coming to how it adds into universal healthcare coverage. So Sehat Sahulat Card is in health insurance. Like private providers provide health insurance to their employees, Sehat Sahulat Card is an excellent initiative that allows anyone with a CNIC in a particular province to get admitted in a hospital and up to a certain limit, use their NIC as a health insurance card and get covered for maybe a bypass or maternity or anything which is covered. This opens massive privilege for people of Pakistan for their healthcare to be covered. But again, this is tertiary care. And anything which is tertiary care, in order to prevent that, you need to start from the primary care. And unfortunately, in Pakistan, there aren't as many doctors, there aren't as many hospitals, there aren't as many basic health units to cover primary care for the population that we have. So how companies like Sehat Kahani or maybe Dawai or other companies add into it is, you need to start a Sehat Sahulat Card initiative for primary care. And since you will not be able to manage it with physical doctors because there aren't as many, telemedicine can have a great role to play. Now, the good thing is that the Sehat Sahulat Card initiative officials realize this, they understand the value, and there is opportunity to explore this in the future. What will then happen is that companies like Sehat Kahani or others will provide services either online or through hybrid clinics as Sehat Kahani has. And instead of billing the patient, they will bill the government. And one thing that we have done to kind of quantify that and prove that works is, we have partnered with the government of Azad Jammu and Kashmir. So it's not Gilgit Baltistan, I'll just correct you there. It is the government of Azad Jammu and Kashmir. And what we've done is we've taken 13 of their basic health units, which did not have doctors, and we've converted them into telemedicine centers. And instead of the patient paying us, as it happens in our other clinics, the government is paying on behalf of the patient. Now, this is a revolutionary step that tells you that as a patient comes into primary care, it's covered by the government. As the patient walks into tertiary care, it's covered by the government. But innovation is, in a tertiary care, it's being done by physical doctors because they are available, and a primary care, it's being done through telemedicine because it is available. And I see a massive opportunity in telemedicine playing a very important role in the Sehat Sahulat Card, because over time, Yeah.
Sorry. So this is a good point. So I just want to jump in here. So, but with this system, will the flow be primary, secondary, and tertiary? Because in Pakistan, it's the opposite. It's tertiary first, although it should be primary first. Does that?
Yeah, so I think the flow in Pakistan in a public healthcare system is a patient comes to a basic health unit, then to a tertiary, then to a tehsil or a taluka healthcare hospital or a district healthcare hospital, and then they should go to a tertiary care center. The only reason why patients land in tertiary care centers is because there are no doctors. The majority of the times, doctors or facilities or medicines are not available at the primary care center. Now, this really chokes your tertiary healthcare ecosystem because as many patients are coming there, it's exhausting the doctors, it's exhausting your resources. And the worst thing is, the disease that can be stopped at a high blood pressure level is turning into a heart attack. The disease that can be stopped at a high blood sugar level is coming with end-stage diabetes mellitus. So majority of the times, patients come in tertiary care hospitals when they do not find cure in their faith healing methods or their community clinics. And by that time, you can only cure them. You can't do any preventative methods. Majority of patients.
Sorry. So are we not investing enough in primary healthcare, or there's an infrastructural problem over there as well?
I think it's a
maybe lack of human resource.
Yeah, there's a whole plethora of issues. There is obviously the number of beds per patient is lesser. The main problem is that there are qualified doctors are not available as you move out of the cities into the lower cities. So when you talk about urban areas, Pakistan has 245,000 doctors. A lot of female doctors don't work. Even if you have 100,000 doctors, which is half a patient for 1,000 people, 85% of them work in the urban areas and 15% in the rural areas because they don't have facilities to stay to work. When they are given facilities, for example, the government of KPK started hiring doctors at a higher salary in basic health units and put them on rotation. Doctors started going there, but lack of incentivization, good infrastructure available for doctors just pushes them into the cities or even outside Pakistan. So if you want to create a democracy in healthcare between primary and tertiary care, you have to include digital healthcare initiatives to make that democracy between a low income and a high income area.
Excellent, thank you. So I'll quickly wrap this up now. So we can think of technology as something that will solve a problem. The WISE journey has shown that there's an important element of trust building. So unless there's no trust, adoption of technology and it being widely accepted, the incidence will be very low. Technology to and not in itself. Sarah has shown to us that with Sehat Kahani's journey, there should be an important focus on primary healthcare, and technology could again solve a very important problem in that regard. With Eamon's slosh AI, we learned that government support is extremely essential if we are to innovate in this sector, and you know, regulatory support, especially for a public good such as health, should not even be debated, in fact. So I'll close by thanking all the panelists for joining this webinar and sharing their valuable thoughts and insights. We hope they will prove useful to all the stakeholders. Thank you. And
thank you, Lee. I hope everybody can hear me. Thank you so much for your valuable contributions. And I would like to request, if you guys have the time, especially panel 1, if you can answer the Q&A in the chat box below. Unfortunately, we do not have the time to take them live on the webinar, but if you have the time, please answer them. We do have some great questions. Now, I would like to ask panel number 2 to please turn on their cameras, and I will briefly introduce them before handing them stage to Naveed. So the second panel is titled Unlocking Access to Quality Healthcare, Navigating the Landscape of Financing. The panel will be moderated by Mr. Naveed Guraya, who is the Chief Investment Officer of Karandaaz. He has over 30 years of global experience in leading investment banking and asset management business in various global banks in the MENA, North America, and Pakistan. As for the panelists, we have Ms. Mona Hassan, who is the Principal Investment Officer for IFC. She's a seasoned investment professional with extensive experience in corporate and project finance, leading large-scale debt mobilizations and executing private equity investments. She is currently responsible for business generation and investment processing for IFC in the GCC and Pakistan across the manufacturing, agribusiness, and service, including health, education, retail, and property industries. Next, we have Mr. Leandro, who joined British International Investment in April of 2020. Previously, he held several positions at the cabinet of the President of Argentina. Prior to that, he was a principal at Capital Group Private Markets, doing private equity investments in emerging markets, and also worked for BP Alternative Energy in the wind power business in China. Next, we have Mr. Ahmed Jalal, who is the founder for Cordoba Ventures. He is a venture builder, operator, and investor in health tech, fintech, and logistics in the MENA region. Previously, he ran large healthcare, educational, and logistics enterprises. He was the executive director of investment banking at Goldman Sachs and founding team member of the Evercare Healthcare, and he's a chartered accountant with Deloitte in London. We have Mr. Atif Awan, who's the Indus Valley Capital, early stage VC fund focused on Pakistan. It has been the first institutional VC to back many category leading startups, including Bazaar, Marham, Bridgelinks, Markaz, Remote Base, and Maksad. Lastly, we have Mr. Kashif Mustafa, who is the managing partner at Laxon Private Equity. He, in addition to his role at Laxon Investments, he also leads their portfolio company OMI Hospital, which is a highly respected tertiary healthcare institution providing cutting-edge medical care to the patients. And with that, I would like to hand the mic to Naveed so he can kick us off.
Thank you, Hassan, and appreciate your introduction of all the panelists. Let me extend a thank you to all those panelists who are working or joining us from different time zones. Our gratitude. To set the stage for our conversation, I'd like to basically take our discussion with a quick perspective of where we are. A lot has been discussed over the last hour and a half, and starting from the keynote speakers to the presenters of the study and the previous session in which the demand side was speaking. Now, Pakistan clearly lags in the health indicators, both in the developing markets and in its peer group. And this study tends to unlock or identify those gaps and hurdles that are need to be overcome to fill those gaps in achieving a higher rating in those indicators. And all of us have heard it's a massive task requiring massive capital. And all these sources of capital, the ones that are present around the table today, are or have a big role to play in that. Now, some of the key challenges, if I can summarize from just the key ones that are probably relevant right now for this brief conversation we're going to have, is that at the patient level, affordability and accessibility are the first key hurdle that needs to be overcome. Secondly, there is, in my view, a lack of a peer-provider relationship. Sehat Sahulat Card has participated in this, filling this gap, but there is a big gap that further needs to be filled by other insurance products and perhaps participation or subsidies from other areas. And the third one, for which we are gathered here, the largest gap in my view, is the lack of capital in developing the infrastructure for this. Now, a word about why this study is so important to Karandaaz is that we, as an impact investor funded by FCDO, have healthcare as one of our top 4 strategic pillars in our strategy. We have made several investments in the healthcare sector, which include in the pharma manufacturing space, and our CEO Waqas mentioned a couple of them earlier in the session. A key one is in the dialysis product manufacturing. We also have funded a biopharma product manufacturer, which had a dual use of vaccine fill and finish capacity. And the third one is in the diagnostic laboratory chain, which is one of the largest in the country. We continue as Karandaaz to look at primary, secondary, and specialist healthcare facilities. And we are also looking at health tech as an area where we have had a lot of input from the participants today as an area of interest. But trust me, this is a big venture, and capital is required by partnering with capital providers such as yourselves and others in the market, which include public sources, which include development finance institutions, which include private equity funds, venture funds, and foundations as well. So there is a whole range of investors and ecosystem that needs to come together, but we also believe that it has to be done in an organized manner. It cannot be an opportunistic approach. Sure, opportunistic approaches are needed for capitalist system, but at the same time, a programmatic and a systematic approach by partnering with institutions in these categories are important. Now, participants on this panel, as I mentioned, are from development finance institutions. We've got Leandro from BII, director, and we've also got Mona from IFC. And then we have our private sector, private equity partners on the call as well, who are investing in both the private equity traditional and startup space. I'm looking forward to this conversation, and ladies and gentlemen, welcome to the forum. Starting off, Leandro, if I can, have the liberty of starting with yourself. First of all, welcome to the forum. BII, British International Investment, formerly CDC, is one of the largest investors, clearly the oldest DFI, but the largest investors in Asia and Africa in healthcare. So therefore, you have a history or a deep knowledge of investing in the segments or the type of developing markets that are difficult, and you have had success and experiences in most of these markets. Now, we do understand that, and here is something that we would like access and affordability in underserved areas in these economies or in these markets is something that is dear to BII. That's a difficult space to operate in because the sustainability of these models becomes difficult to establish, especially when you're operating at the bottom of the pyramid. So my first question to you, Leandro, would be, first of all, if you could talk more about your strategy in terms of the socioeconomic pyramid that you target, but how are the challenges of affordability addressed by you in these markets with the concept of sustainability of the investment that you're making? So if I could turn it over to you, we'd love to hear your thoughts on that.
Well, thank you, Naveed, and I hope that you can hear me well. Yeah.
I'm sorry, could you? Yeah.
Can you hear me well? Okay, great.
Yes, we can hear you.
So, well, thank you, Naveed, and congratulations on the report again, and thank you for inviting us to the panel. As you said, BII, former CDC, is one of the largest investors in health in emerging markets. Probably today, it represents 10% of our $9 billion. So around $900 million are investing in health across Africa and Asia, South Asia for us, mainly. And that has been from pharma to medical devices to healthcare delivery, everything in between. When I was listening to the previous panel describing the situation in Pakistan, and if you change the name Pakistan for Kenya, or you change the name Kenya for Nigeria, we could have been having this panel for any other of those countries. So anyone who is in kind of that, income per capita bracket is facing the same issues, is trying to use technology in the same way to basically unlock access. So this is not new, it's happening around the world. I'm very optimistic because of technology. I think it's really, technology is lowering the cost of supply and allowing access in a way that I think pre-COVID, we would have not imagined. COVID was a big change in terms of people's, not that the technology was not there, is the ability of people just to converse with that technology and be open to use the technology. The way you were thinking, how we think about access and affordability, and you're absolutely right, is the conundrum. Because in an absence of a health system supported by the public sector, or that allows people to have access to private care, which in our markets, it's nascent. Pakistan is doing it with a card now in some places. It's nascent. Let's see how it goes. India did in a couple of states. Kenya has more experience. And we all know that some of these systems have been very difficult for investors to navigate, both in terms of business integrity issues and in terms of time of payments. This has happened across several of these markets. So it is difficult. But as I say, it happens everywhere. And what we are seeing is that we can combine, the way we are thinking about this, and we're doing it, is invest in models that can combine both patients that can pay, which there are patients that can pay in every of these countries, and in some cases these patients go elsewhere for treatment. I was in Kenya recently, and even people have their specialties in mind when they travel abroad. So for these specialties they go to Germany, for these they go to the UK, for these ones they go to Dubai. So there is a lot of potential demand there, and I know it's a niche, but that niche can pay and then can cross-subsidize the care to patients that cannot pay. The way we are thinking about it is we only want to invest in hospitals that have at least 30% of the patients coming from public schemes or people living under $8 a day. And we put ourselves in that kind of structure because we want to force our investments to really develop the ecosystem, right? So you can argue that any hospital that you build today in Pakistan will develop the ecosystem because it has 3 or 4 high complexity hospitals in the whole country when you compare to 50 plus in India. Anything that you add in Pakistan today, it has 10 PET CTs in the whole country. Egypt has more than 50. So anything that you throw out there to put in a way is going to be impactful. But we want to force ourselves to, from the get-go, to be serving patients in the lower part of the pyramid. So how to do it? I think is one is to anchor any new hospital or tertiary facility on a few core disciplines or specialties that allow people just to be known as a reference. We did it with Rainbow Hospitals in India, and that means that people from other cities began to travel to be treated in that place. It can be that it's a mother and child facility, it can be spinal surgery, it can be neurosurgery, whatever, but you need to anchor your facility in something that is known for. And there you create volumes from the high-paying customers, not from the first 2 circles around you, but just people that come from other parts of the country. And then reserve a part of your capital, and that can be a blended capital solution for basically caring for patients that cannot pay. So I think a solution could be today that you build something that has the card as a potential payer. I would personally not build something that relies only on the card, given that the card is still nascent. But then, in my trips to Pakistan, I discovered that there is a huge, probably is the country, of the countries that I travel around the world, I felt that the the donation ecosystem in Pakistan is huge, right? And any big investor that you talk that they are in manufacturing or etc., they have donated to a hospital. There is a big donation community. So I think that there is the ability to create structures in which has a company and a foundation on the side, for example, that gets money from donations, and then you create a blended capital facility that allows you to cater to these 30-40% of patients that cannot pay. At the same time, I think that some of the models that we've seen have been interesting. For example, in South Africa, is that hospitals or tertiary facilities that want to cater to these communities, they have also started to develop their own health insurance plans or prepay plans, in which for very little money, they start creating their own ecosystem of payers, which is the other angle that we are very interested in developing, which is the health insurance market. In all these markets across Africa, with the exception of South Africa and India, the people that are insured probably is 2-3% maximum. So that's the other angle, is working with the tertiary hospitals that you build, or with technology companies like fintech, that they have huge communities, in order to launch low-cost health insurance products. I was seeing in the previous panel some people doing that already, right? So, and particularly focusing on primary care, which I think is a great idea, right? 80% of what you need to be sold on a day-to-day on your health is probably a primary care issue, but you need a tertiary care backbone. So all these are strategies, Naveed, that can be done. I mean, yes, it's challenging, but it's not very different from other parts of the world.
Right. So a quick follow-up question to that. I know we've had the opportunity to talk about these things in the past as well. Taking a center of excellence, either in a tertiary or specialized hospital, and using that to subsidize, or in a blended way to provide affordable healthcare to the lower economic segment, is an interesting approach. And now, has BII been able to execute this model in any of the countries? You mentioned Kenya, but is there an example that can be looked at by our private sector, and they can draw a lesson from it and perhaps copy it from your experience?
Yeah, I think that in some of the examples in which we have invested in the past, like Narayana Health, we exited now in India, etc., or where we are now invested in Egypt in Alpha Medical Group. In all of these places, we've had this initiative to lower the cost of supply in order to make it affordable to the people under $8 a day. In some cases, that meant launching a second brand, for example, in diagnostics, that probably doesn't have all the just all the accommodation and everything that you would see in a top-end lab or scan center, but it does the job extremely well and allows you to penetrate in other parts of the country. And also, you may not have the radiologist or some people there, but then you can do it remotely from the center. So that is what we're doing in Egypt. And then in the case of India, we've seen the ability, once you establish a center of excellence, your ability to lower if you establish a center of excellence, what happens as well is that you are able to run it very efficiently, and also includes how your relation with the clinicians, right? So you escape the star doctor syndrome in a way. So you can, in a way, lower the cost of supply by not having, you don't need to have the renowned specialist. You become known by the brand itself. It's a very difficult thing to do. But once you do it, then you can provide quality care at much lower rates. So it can be done. In Pakistan, I would like to try this foundation next to the company approach, because I see a huge donation community. A lot of people wanted to donate, and I would love to set up a blended facility for tertiary facilities in the country, and I think it can be done.
Okay, so you've answered my next question, which I was about to ask, that what will make you invest in Pakistan? So thank you for preempting that. If I could, in the interest of time, just move on to Mona, and then I'll come back to yourself again. Mona, at IFC, as the Principal Investment Officer, you have a clear sight of the healthcare investments that IFC has done. They're about $3.5 billion or so across a whole range of countries across the world. And again, as a DFI, it would be extremely interesting to know that the investments, when IFC looks at in these various countries, it view the pipeline, especially in respect of Pakistan, because I believe you might have invested in a company and maybe you can talk about it. And when looking at these globally, what are the criteria you'd look at, and with specific direction to Pakistan? What kind of pipeline did you look at, and how did you arrive at a decision to make the investment? So if you'd like to address that, that would be very helpful.
Sure, thank you, Naveed. I'm afraid I have my camera on, but I cannot see myself. But do you see me?
No, we can't.
I don't know why it's not working. It was working in the last call I was on, but it seems that my camera is not working, but apologies for that. Congratulations on your report, and I'm very happy to be here to join this session. So maybe a little bit about IFC and our investments in healthcare globally. So yes, you said we have an active portfolio of $3 billion, but overall we've invested $6 billion in healthcare across the globe, about half in medical services and half of that in the pharma space. And medical technologies is another growing space for us that we are looking for, to support. When we, our mandate is to help countries accelerate towards achieving universal healthcare, and we want to expand affordable quality healthcare across the countries that we work in. So when we talk about healthcare, IFC invests in health services, in pharma, and in medical technologies. Within health services, we try to look for the scalable models, networks of clinics and labs and primary and secondary hospitals. As IFC, of course, we being a DFI and our cost of financing, we cannot look at the very small ticket size investment. So we're looking at the scalable networks. And when we invest in a hospital, we're looking for a center of excellence, really. And that is the investment that you mentioned, Shifa hospitals. Then we are also looking at public-private partnership models to support, to bring private provision in service delivery and in the infrastructure. So in Pakistan, we've invested, I think Shifa is one of our flagship healthcare investment in Pakistan, but more recently, we've invested in the Northwest General Hospital. As of November 2022, we did an investment over there. We are currently working with the KPK government as lead advisors for a 500-bed tertiary care hospital to be structured under the public-private partnership. So we are we are the advisors, and we will, at the stage of investment, look at being supporting the winning bidders for this project as well. Then through various funds, we've invested in the Global Healthcare Fund, and through the Evercare Fund, we are indirect investees in the Evercare Hospital in Islamabad diagnostics. Through our investment in Samayaka, we are indirectly investing in Dawai and Olodex. So we're expanding our footprint in the healthcare space in Pakistan. And currently we're looking very closely at the pharma manufacturing space. We have a growing pipeline. So hopefully we will be able to support pharma manufacturing in Pakistan as well. So what our challenges are really, we need to find the quality providers, and we need to find the, the scalable models to bring affordable healthcare. What happened because you mentioned Shifa, and I can say a little bit about Shifa. We liked Shifa because we did a very in-depth quality assessment, and we saw that they're already JCI accredited, but our quality assessment also showed that they are very strong on quality, but they also had the same foundation model. So they had the Shifa Foundation, and about 20 to 30% of their patients are the welfare patients. So there is some cross-subsidization over there. So that's how we want to try to make healthcare more affordable. What the previous panelist was also talking about, that is what we see in Shifa. And they have the corporate subscription model where they have a large number of corporations on their panels to make services more affordable to employees of these corporates. In Northwest Hospital that we more recently did, they cater heavily to the Sehat Insaf program. So that is also making healthcare much more affordable for the patients. Of course, tertiary care, when we look at these models in Pakistan, maybe they're not affordable for the population, but they're not expensive when we compare it to regional payers, or the cost of services is not expensive when we compare it to regional payers. It is the population's purchasing power. And there this is how we need to, some state public insurance like the Sehat Insaf and private insurance and the corporate subscription models, the foundation welfare models, they all need to come together to make this more affordable. And of course, the primary network needs to be developed. A primary care network and preventive care needs to be developed in Pakistan, so that it takes off a huge load from the tertiary care hospitals, which are really at capacity right now and in serving their patients, and are under a lot of stress. So we need to grow the hospital network also, because of course the hospital beds for the size of the population is low. But another, I think, main challenge we see, and the client companies that we talk to face every day, is the human resources. Yeah. There may be a lot of doctors in Pakistan, but nursing staff, medical technologists, there is a dearth of, there's that is, needs to be increased. And in Shifa and in Northwest, they have the education systems also. So they are producing the nurses and the doctors and the medical technologists, paramedics as well, to cater to their own needs, but also to serve the Pakistan market in general. So those are the things we really liked when we invested in.
Right.
You can stop there.
So I think you partly answered the question, but you see, there is expansion of footprint can be achieved in two ways. Most investors, including ourselves, worry about greenfield versus existing investment opportunity. And there are merits to both, demerits as well. A new facility, 50 to 100 bed, could cost anywhere from $50 to $100 million in local costs, and with cost overruns in rupee terms, greenfield has its challenges. It appears that most of your investments have been directed towards existing facilities. Is that by design, or you're looking at entering into new projects, big ticket? that address the point that you're making about center of excellence, creating that, and then scaling it up as per the JCI standards or any other benchmarks that you set for affordability and accessibility.
Right. So, I mean, I don't think we do less greenfield investments because you know, hospitals have a longer gestation period and you need to find the right experience in hospitals. It doesn't mean that we don't do greenfield, we do. For instance, these PPP transactions that we will do will be new hospitals, but it has to attract the right kind of investor also. So, you know, doing greenfield with corporates or players, sponsors that do not have healthcare experience, of course, it's not something that we would be interested in. But you know, sponsors who have healthcare experience maybe elsewhere and are growing into, you know, maybe have a labs chain or a clinics chain and are growing into a primary, secondary care hospital and have the financial muscle as well as the experience, we would look at it and we can support them. But it has been challenging to find those sponsors for greenfield projects. So we have not done many of greenfield projects. Not only in Pakistan, across the globe, we do less and less of them. But we remain open with the right kind of sponsors.
Okay. So today, and our participants in the audience would love to all the participants. If you were to invest in Pakistan as your next project, what is the nature of investment that you would look at in terms of participating, and what kind of ticket sizes does IFC look at when participating in healthcare facilities investments?
So IFC, of course, as I mentioned before, we need to have the quality, the experience, and ticket size for us has to be sizable. So we would maybe look at, you know, a project size of $50 million in which we can at least do $10 to $15 million of IFC investment. But for the smaller size, for the smaller ticket sizes, we look at investment with funds and with banks. We provide lines to commercial banks to on-lend in particular sectors. So for the healthcare sector, we could do a line for the smaller $1 million ticket size projects. We do that way. We don't do direct investments because, you know, our cost of financing doesn't make sense for the sponsors.
Thank you, Mona. I'll come back to you in the second round. Our next participant, Mr. Ahmed Jalal, is the founder of Cordoba and has experience in working in both private and social enterprises. And Ahmed, it would be very helpful to learn about, very briefly, your journey and how you have, as a private investor, investing in the country and elsewhere, found your feet in where a lot of others have not been able to raise capital or invest. So a continuation of that is that what type of business model or strategy do you feel can be adopted by private investors to enable better outcomes and sustainable operations, keeping in mind the end consumer or the patient, as we might call it? So it's a rather large question. Apologies for that, but over to you.
Thank you. Thank you very much, Naveed. And I must congratulate the Karandaaz team for the, in essence, the healthcare infrastructure build out that you're doing, which is data, providing the data. I think that's the starting point of any investment, any successful investment. is data. And I think there's a huge lack of data in Pakistan. So thank you for making that available, making a dent in that. I've been an investment banker. I've been a private equity investor. Then I was an operator running a healthcare enterprise. And I've also run in a foundation, healthcare foundation, as well as public-private partnership working with the government. And so I've got experience across private, not-for-profit, as well as public sector in healthcare. I think healthcare sector is unique, is very different, is complex, is difficult. There are 10 ways to make bad investments, and there's only 1 or 2 ways to make the right investment. You know, in e-commerce, other places, it's simpler. The access to people is more simpler. The market is more simpler to understand. Healthcare is a technical area where complexity of service delivery, technical of management is more than in other businesses. And the reason why I say it is because your consumer is your doctor. And the doctor has huge amount of power in making your investment successful or not. And the asymmetry of information that is available with the doctor is unlike any other sector. So you really have to work through the doctor, with the doctor, in order to make your transformation, make your investment a success. This is not the case if you're investing in FMCG. This is not the case in investing in other sectors. So I think it requires a special approach. I don't think you can do it like you invest in other ventures in other sectors. So mirror to view here, the way I look at it is that inherently it is a longer term investment than most other sectors. You have rightly pointed out, it takes 3 to 4 years for a hospital to get to break even. It can take shorter and probably take 5 to 7 years for it to mature. So by nature, any healthcare private investment cannot be done on a 3 to 5 year VC PE life cycle. It can't be done. It has to be 8 to 12 years, which is the where the Evercare idea came out about a permanent capital vehicle or a 10 to 14 year vehicle. That's the number 1 point. If you try to fit in your healthcare asset within 3 to 5 years or 5 to 7 years investment, there's nothing wrong with the investment. There's something wrong with your timeline. So I think that's one thing that we need to get right, that it is by nature a hugely a different kind of investment that takes much more longer to mature and much more longer for it to get the return. So number 1, that. Number 2, you need a different breed of investor. Because you are dealing with, you need people who are technical experts in healthcare, because most of the time you're dealing with doctors, and doctors are, for one reason or another, in our country, in our culture, put on a pedestal, and they don't think much of you. Even if you've been to Goldman Sachs or any other place, they don't think much of you. They only think much of any other doctor. So you have to come with a lot of technical expertise and knowledge to make them believe that the value add that you do is of value to them. So you are looking at specialized. So you're looking at longer term vehicles. You are looking at specialized vehicles that go on to develop a healthcare ecosystem platform, because the nature of the investment is such that you cannot do it on a generalist VC PE way. It's just more difficult to do it. You will be able to do it, but I think it'll lead to more problems. So that's my number 2 proposition of how to go about doing it. Number 3, I think what you have to think about, and I think Leandro mentioned it, it's somewhat complicated. The actual value may come in not in pure equity, but what you call impact bonds, where you blend equity with philanthropic capital, and you're looking at returns which is based on reaching certain impact and operational KPIs, for the investor. Impact bonds is a big area in both development financial institutions. And I think these are the instruments that could lend well, as in they lead to less dilution, and they align long-term operational ESG incentives of management with those of ESG compliant investors like the IFC or like CDC or BAI as is currently known. So that's the other thing. The challenge that you'll find is that Pakistani donor, which Leandro is very excited to know about, and there are lots of them, are not philanthropic visionaries. see, they're not visionaries like the Carnegie Mellon, and because they focus on just the impact, just relieving pain, not systems transformation. And the reason why I say Carnegie Mellon is Carnegie Mellon Essential University is a not-for-profit initiative, but it's such a good not-for-profit initiative that whether you're a wealthy guy or you're a poor guy, you want your children to go there. There is no not-for-profit in Pakistan that works on that basis, whereby the wealthy will use it as much as the poor would. It's built for the poor people. It lacks in quality. It is all about service delivery at lowest cost, very little regard for quality. There are some places which are doing a better job, but the primary objective is service delivery at a low cost. That's not how philanthropy works in the West or in the US or in the UK that we are used to. So that is a challenge there. I think number fourth area, I would think that you would need a huge amount of, you would need private capital, is probably you would need to create a healthcare REIT. Because what is the biggest cost of investment? You know, I would hope it would have been people, but it's not people, it's real estate. It's a totally useless piece of real estate that you need to buy, and you need to put $10 million before you dig a hole or you do anything. It's the most expensive thing. It is the thing that makes the ROI very small and very low. So either you work with the government and you increase the amenity plots, which are cheaper, you know, are very much in high demand, but they are much cheaper. So you increase the pool of amenity plots, make them available, or you create some kind of a REIT, real estate investment trust, whereby you can buy land for hospitals, or a hospital operating company has the ability to buy land through the REIT, and then they can earn the return on the operating part of it. So I think that's the fourth element of any investment that I would have. The fifth element what I have is the training and development. By all means, the service delivery, the quality of service delivery is dependent on one thing and one thing alone, and that is the man or the woman providing the service delivery. Here, we again have a problem in culture. We have too many doctors. We have too many surgeons. We have too many, and not specialists. I think we do have shortage of specialists, but we have a lot of doctors relative to nurses, allied healthcare professionals. I think the global demand for allied health nursing is humongous, and so is in Pakistan. Normally, there should be 3 nurses for every doctor. There are 3 doctors for every nurse. So it's a role reversal. And literally, you need 5 nurses and allied health per doctor. And I think we would be only at 20% or 30% of that WHO standard. It's not a glamorous area of investment. It is not an affordable area for people to get education. It is hard work, but ultimately an investment in that area is going to be the most impactful, the most long-term transformative to build the backbone of healthcare by training the allied health and nursing professionals. I'm sitting here in Cordoba Care Institute of Health Management, which is one of our investee companies which we've built, which is all about transforming nursing and allied healthcare. And because I've seen it running hospitals, also an ambulance network, we needed 700 paramedics that we were always short of those. And now the world is short of those. So I'll stop at that. I have a lot more to say, but I'll stop at that, give you a time for a follow-on question.
No, that's fantastic. Thank you very much. And one of the common themes that seems to be coming out, Ahmed, and we have more participants to speak to, is that the nature of investors, which is, we're talking of philanthropic entities, foundations, all have a different approach, whether perhaps DA is a special or perfect candidate for that. Now, I want to ask you 2 questions. One is, if you could, you mentioned that the model in the West is such that these foundations have a different mindset versus those in Pakistan. What about emerging markets, other development developing markets. So that's first one. And the second is that actually it's more of a comment. I agree with you on the REIT structure, because that again is an income support structure. In the West, personal experience on doing doctors' offices. I mean, ancillary facilities, but within that, and that's a complementary income stream that supports the operations. So I'll stop here and pass it back to you to talk about the funding structure in developing markets and comparing it to Pakistan.
I mean, any money that comes from IFC, BI into Pakistan is highly welcome. But in healthcare, I think they have to take a different approach. This 50 million dollar transaction, large single ticket is difficult to execute. VCs are going to be somewhat disincentivized in taking risky plays. So they're going to also invest in more safer bets. I think what we need to look at is some kind of a greenfield fund. Maybe IFC has a corporate venture fund, and look at smaller transaction or facilities or create a vehicle. Maybe I'd pitch in for a Karandaaz. Maybe use Karandaaz as a vehicle to making these smaller investments. And the kind of investment I'm talking about is the Narayana Health in India. These are highly innovative. The first time it was put in, cardio operations being done in a highly processized way, in a very non-traditional way, to cut the cost of a cath by up to 20% or 25% of a normal price point, or something like the Aravinda Eye Healthcare, which are highly what I would call making like a production line approach to healthcare, rather than this magical approach that we have, which is that doctor in the center of everything and he has some secret ingredient. And can you processize it to reduce the cost? And actually backing innovative teams who would do that, such kind of investments in Pakistan in a smaller ticket, pilot it, $1 million, put them there, then another $5 million kind of follow-up, and have a very robust scale-up strategy. Because I think these, whether it's a Shifa or other big hospitals, these are incremental changes they're going to bring. Anyway, money is very welcome, but there's not going to be a game changer. A game changer is going to be a startup, a very highly specialized in eye care or a cardiac cath lab unit or a diabetes kind of clinic model that is able to scale up very, very quickly. To give you, and one of the reasons that hasn't happened in Pakistan is lack of private equity. And, I'll go on about example of Shifa is because, and no other reason, they are very good people there. But Shifa started in 1987. Apollo Hospital started in 1983 by Dr. Pratap Reddy. Apollo has 10,000 beds. And Shifa has probably 11 or 1,200 beds. There's a huge delta in performance and scale up. And that probably didn't happen is because Shifa probably didn't have access to such kind of visionary capital or high risk capital that Dr. Pratap had, that Apollo Hospital had. It had to go eventually for listing in 1994, 1996. And that kind of made it even more, risk averse. So I do think that kind of models applicable in other places, successful in other places, have a space in Pakistan, and BII and IFC and Karandaaz have a big role to play in it. Thank you.
Indeed. No, thank you very much. I think this is extremely interesting, but you raised another point for which I'll move on to Atif. Atif is the managing partner of Indus Valley. Atif, you've invested in, there's this discussion and there is this, of course, McKinsey loves to coin a terminology, and we love them, the virtual hospitals. And you've invested in early stage, high growth investments, and Maram being one of them, of course, and there are more. Health tech, innovative investments, these are something that need to be explored in every market. Now, Atif, if I could request you to address that, what are the challenges that you see in the adoption of the technology that you're investing in by the consumers? So if you could help us understand that, yes, the platform exists, yes, it can be replicated, but what are the challenges you see in its adoption by the underlying consumers?
Thank you, Naveed. Thank you, Karandaaz, for getting us together, and congrats on the launch of the report. I really like the points Ahmed just made before me, so I'll build on that. And I'll start by the importance of seeing things as they are, right? And I feel in Pakistan, you have to understand the real problem. If you look at the number of doctors in Pakistan per capita, we actually are ahead of India. Number of hospital beds, we are ahead of India. Number of Pakistani or Indian doctors who go to the UK, we are ahead of India per capita basis. So it's not a quality issue either. Nurses, we are behind, like Ahmed said. So we should be investing more in that. And that's where you'll get the higher yield. And then the second point I would make is healthcare is a fundamental problem. Like our outcomes, we lag most of the world. There is a lot of work need to happen. But if you go about it by building more large hospitals, it's going to take you decades. Our population outgrowth will outgrow anything you can do. You're never going to solve it. So you have to use technology, right? We have the supply problem. You don't solve it by, like having just an incremental 3% more increase in hospitals. You solve it by creating a 50% increase in efficiency of existing doctors. And that's where the technology comes in. So I'll give you the example of Marham. It is easily the most capital efficient investment in our entire portfolio. We are a sector agnostic VC. We invested in e-commerce. We invested in edtech, health tech. Marham has raised only $1.5 million total. They're already served more than 1 million bookings. They have 30,000 doctors on their platform. They have multi-million-dollar revenue, annualized revenue run rate that's growing 10% month over month. And they have been consistently profitable for the last 6 months. So that's what's possible when you use technology. And that's only possible when people are using it. And the reason people are using it is very foundational. We have a lot of doctors, but a lot of women doctors don't practice, as Sarah mentioned earlier. This rural-urban divide, it's massive. And there is this elite doctor set. So doctors who have been around for a while have built a brand. Everybody wants to go to those doctors. And that the young doctors that are coming out of medical colleges actually are earning very low income, right? So they have a fundamental problem. They're very good trained doctors, but patients don't want to see it. And that was because of the information gap. So Marham solved that. If you're a new doctor, you join Marham's platform, initially they will send some appointments to you, patients will rate you, and then Marham does not care what your brand was. It's getting actual data after appointment to rate doctors and surfacing the best doctors and moving them forward. And now that solves your supply problem in a very meaningful way because you remove that information gap. That's why you're seeing that fast growth happening in Marham. So we have been actually really, happy with our investment, seeing what's possible. And now we see some other areas. So Marham is a health super app. It's created a basic marketplace. You can find doctors, do an online consultation or make a booking to go see them in clinic. And that's very foundational. But there are a lot of other things in technology that will really help. For example, the focus on chronic diseases. We have a huge problem with diabetes, such a young population, such high diabetes prevalence. And again, it's a data issue, right? So rather than solve that diabetes at an advanced stage by saying, look, we need more people, we need more clinics, I think you solve it by building the tech where you integrate with the labs, you integrate with all these doctors. And the first time somebody has that result that says, look, you're pre-diabetic, or you're maybe just, first diagnosis of diabetes, that's when the intervention needs to happen. It needs to happen with consumer tech. There's a lot of behavior adaptation that you can use through your smartphone because you're always there, right? So that's a huge vector. AI-assisted diagnostics, huge opportunity. AI is, I think of AI as this third wave of technology. The first was internet in late 90s. Pakistan and emerging markets were too poor. We were low-income country back then. You could not avail it. Internet was a luxury. Second wave was mobile, 2008. We didn't have enough smartphones or 3G. Now the third revolution is AI, but now we have internet, we have smartphones, we have smart people, and this is the time to really, really invest in that. And that's another vector where you improve the doctor efficiency massively. And it can be as simple as there is this, while you're doing the consultation, there is an AI listening to it, and the doctor has to do nothing else. And by the time the doctor is formulating thoughts in his head, the AI gives a bunch of data to the doctor as well and saying, hey, you should think about that. And now you can see more patients faster as a result of that. So I'll pause there, but I would echo what Ahmed said, is that, there is this need. We can take the early stage risk, but we would love the DFIs to, be more open-minded about investing in an earlier stage. It's not as risky. There are structural ways you can create vehicles to do it. And I think you'll see much, much faster impact than creating, another Shifa over the next 5 to 10 years.
So indeed, I think one of the things I'd like to share from our experience is that we've looked at some investments along the way, health tech. And when looking at the customer base, we found it so interesting that the client divide was such that there's a lot of rural population that was and also through feature phones as well as the smartphones. Now, in your experience, if I could ask, when you look at the investments and the companies that we're talking about, is there such a penetration in the underserved areas that you see, which overcomes the need to set up a lot of hospitals?
Definitely. So we see the same. Some of the strongest advocates of Marham tend to be from these far-flung areas, rural areas. And it makes sense. Their alternative in the past was you are in South Punjab or interior Sindh, you want to see a good doctor. And healthcare is one of the things where it's very personal, it's emotional. Even for the, obviously for a very serious condition, you want to go to the best doctor. But even if it's not life and death matter, people care for their families. They want to go to the best doctor in the biggest city. So people who are traveling to Lahore, they were traveling to Karachi. That is very costly, look at the fuel prices. You have to go and then find a place to stay. And people are still doing that. And now for a lot of the times, they don't have to do that, right? Your initial consultation can happen there. Diagnostics, I think you have pretty good access with diagnostics lab. Khan, Shaukat Khanam, a lot of labs have networks into these areas. So you get the test results and then you only go once and then follow-up can happen, online as well. So definitely seeing that. And I think that's very important. And that can be paired with, again, having smaller centers. And if you invest in nursing, so you can have actually physical locations in these villages and smaller towns as well, as part of, let's say, Marham chain or any other startups chain. That then makes it easier to take your vitals, and there is a nurse that can do that, and the doctor has real-time access. And it's all about increasing productivity per doctor. And I think the rural areas are actually the biggest beneficiaries of that.
So Atif, staying with the theme, and my last question before I quickly move on, sources of capital being the biggest hurdle among, of course, as an investor, as an investment person, I always lean towards that. What sources of funding do you see with the panel here, and where have you been able to be successful in sourcing funding for your projects or investments?
Sure. So we are a VC fund, and we're early stage. So we have had a lot of success with, individuals and family offices. That's what our focus has been. I believe it will evolve towards DFIs and, more institutional investors as we scale up. And I think most early stage investors in Pakistan are at kind of that stage. Some of them have raised from BIA and IFC. So I feel there is a lot of interest because Pakistan in many ways is a late bloomer when it comes to startup investments and technology in general. So we can learn a lot. What Leandro was saying that, look, you can replace Pakistan's name with, one of the other countries, and it seems very similar. So there is a lot for us to learn from these other markets, which then lowers your business model risk and market risk, because you know what approaches have worked and what failed. So you're not going to experiment with the ones that failed. And I think that makes Pakistan such an interesting opportunity. So we actually current capital downturn aside, we've gotten very positive response in general from investors and excitement. I think the bridge that we have to now cross at a larger scale is, you get the smaller checks from family groups, the DFIs, and for good reasons, their minimum checks are quite large, and then there is this gap in between. And that's where we have relied so far on the larger VC funds in US predominantly, but also in MENA and Europe to some extent. And that's being negatively impacted by the current capital downturn, because what happens is as interest rates rose, VC funding across the globe, they're now down by more than 50% year over year. And when that happens, the markets that get impacted the most are frontier markets and emerging markets. We're seeing that pull back. And I think that creates this opportunity for DFIs, if they're flexible, to actually plug in that gap and get into some investments that historically they've been disadvantaged to getting in, because the larger VCs, they move pretty fast relative to DFIs. It's just an institutional thing. But now that the market is slow, actually it's a perfect time. You can spend a lot more time. You can, do your diligence process. But there are like lots of opportunities, and we'd love to sit down and dig deeper into that offline.
Thank you very much. Kashif, not to say that it was you're the last on the panel to speak by design. It was just by chance. So apologies for that. We have enough time, just slightly over. Your fund has, you're the managing partner of Laxon Private Equity. Now, your fund has invested in a wide ecosystem. It's in the healthcare space, including pharmacies and a network of clinics, hospitals. So kind of an ecosystem approach that you've taken. Now, that is something which we believe also that is probably very useful in developing or delivering customer experience and building on that. But stepping back from it, this is long-term capital-intensive investments to our, as we feel. So do you feel that public funding sources are something that can play a larger role when you build that ecosystem? And what are the opportunities that you see in the PPP space? So a bit about your experience, it will be very helpful to understand for the audience, and also the PPP segment and public funding sources that you have a view on.
Thank you, Naveed. Yes, it's good to be at the end to get everyone's argument and then see where to fill the gap. And I appreciate the research work that has conducted by Karandaaz, because we have been in the sector. And I have the liberty to speak as a PE manager and as an operator too, because it's been more than now 6 years that I have been in the sector. So I appreciate the merit of the research that you have done, because it helps us and most of the stakeholders, and that would be that's a great. So I would say that why we have, because you could see that all the research that you have compiled, or the direction that most of the panelists have discussed, we have literally trying to do the same thing. We also believe that larger hospitals are feasible, but again they have longer, issues and gestational issues. And at the same time, we could understand that the problem is not the big city. Problem is the second tier and third tier. And I personally believe as in healthcare, because I sit in Karachi, and I know that we see patients coming from Sindh and Balochistan. We have 60% business, or we have 60% patients coming from Sindh and Balochistan, and that's the situation of most of the hospitals in Karachi, and I'm talking about the private hospitals. Yeah. And that's a great trouble that somebody living in Jacobabad or Bhoti or Kaipur, which are 600 kilometers away, that they have to travel to Karachi. So we always have that clarity that we need to have hub and spoke model. Ahmed discussed about Apollo, and then he compared. I think that's a great analysis, and we have been finding our source from Apollo, because India and Pakistan are very similar. So let's say in hospital management, if my head office is, my main hospital is in southern Karachi and somebody from Jaipur has to travel, you have to divide, you have to work on your footprint and you have to work on your outreach. So we feel, and I strongly feel, and I am happy to touch base few point of your report regarding demand and supply, regarding the recommendation, cities, and so on and so forth. So I feel the way forward is, and where a lot of investment could be made, is to have, and I give you a real example. So let's say in Karachi, and if I talk about Sindh and Balochistan right now, to give you a real example. So let's say if I'm in Karachi, so there could be a tertiary or a quaternary level hospital in Karachi. But as you move forward, then in Sindh, there are three divisions. There could be three divisional secondary level hospital, and the district should have primary hospital, and everything if could be virtually connected as Adit has explained it. So I skipped that part, but that could be done very that you have to back your entire ecosystem with brick and mortar and virtual connectivity. So let's say if I live in Khairpur and I have a problem, I can go to my satellite clinic in my city. I can confidently say, with my little experience in healthcare, that 50% of the answers I'll get from that satellite clinic, and it will be connected to my head office. So the quality, reliable, authentic credential view could also be sought. So let's say if I don't get my answer, to still Sakha may be my divisional head office or my divisional secondary hospital. I could travel 20 kilometers far and get my rest of the answer. And my influx to the quaternary or tertiary level hospital, which in Karachi, is just 10%. It solves the very basic issues that all of us have been discussing: convenience, the pricing, the affordability, the accessibility, and the quality. So that has been the model, and it is still the model, and we would like to expand. So we bought or we acquired OMI Hospital, and our fund is not agnostic; it's just healthcare dedicated. We had acquired OMI in 2018. It was again, as you have explained in your report, 90% hospital are owned by individuals, so was OMI. Since then, we have transitioned from a corporate structure and we work on that. Then we had COVID and economic turmoil situation of the country, so we had to slow down, but then we have opened our second location we are working to set up our second location in Iqbal and the third in DHA. And the DHA one is fully functional right now, and we would like to then expand. And I feel now, and I've touched base on the potential private investment. So I would really disagree that you cannot go to B-tier cities and open your facilitation center unless you are not backed by a reliable name or a head of or a good head office, because you cannot enjoy the economy of scale. You can recall many experiments were conducted, but they couldn't bring fruits to the founder, and they had to shut their businesses. So what I would say, as a person who is into the sector, that the private investors could go to those 98% people owning different hospitals and doing good work, and convince them to be and to buy that corporate model, and their expansion could be into B city as we doing into B and C city. So rather to reinvent the wheel and go without a brand and your support function from your head office. So let's say if I talk about Goldmire, I have that 36 year of legacy here. I have system, I have doctor, and I have the entire staff. And when I have to support my Khairpur or Sakkar or Jacobabad office, I can enjoy that economy of the scale. Now, pretend for a moment that the Khairpur office doesn't have any back office, and they need some complication, how they are going to solve it. So therefore, I feel that the real private investment could explore their way towards those 98% individual owned hospitals to convince them to maybe issue 20-30% right, and then they take them to B-tier and third-tier city. About the funding, I would say that to us, local family offices have been a source, and we had raised in 2017 1800 our 100% fund through like-minded family offices of Pakistan. Now we plan to launch our second fund, and we would like to to the same family offices. Of course, they have been super happy with our performance and the way we have turned around the entire ecosystem. But at the same time, we feel that the DFIs have great interest, including Karandaaz and international DFIs, and then international family offices. And there are many private equity funds which are healthcare focused, and they've been doing good work in Africa, in Kenya, and in India also. They would like to build synergies, and also, in my view, for healthcare and for smaller and mid-sized hospitals, the funding would be sourced from locally and international front, and the opportunity could be mainly into expanding the small to medium-sized health unit, and then you take them to anywhere. You wanna start pharmacy into it, you wanna start diagnostic from that, and so on and so forth. The last thing is that I feel that the private investors could also explore in real-time diagnostics, because we all know that across the world, into developed world, now the reliance is on the high quality diagnostic, and I'm referring more to radiology part, that a good MRI, a good CT, and so on and so forth, so many equipment that I could share here that they could invest. So they say if a mid-sized hospital is running their operation, they want to unfold their potential. So a private investor or a private investment would build that synergy, join hand, and explore into that. So there are so many little things that we could do, but we need to understand that Pakistan, as Ahmed has rightly said, is a difficult territory. Here are, when you come to the ground, there are difficulties in terms of litigation, in terms of dispute on real estate, in form of amenity plot, whether you can acquire it if you are a private investor or not. It's a dispute, and so on and so forth. But I feel that the potential is huge.
Kashif, I think what you're saying is spot on, and you've addressed the point of the funding sources. Now, I have a lightning round, if I can do in the reverse order possibly. So, Kashif, what is your investment hurdle if you were to invest in a project, or your fund was to invest in a project?
See, right now that's a very good question, and I will share with you our own experience, my organization, and my own experience. That from a private investor perspective, and in healthcare I'm talking about, it's very difficult to acquire anything. Trust me, from Karachi to across the Sindh, and mainly in Karachi, we have done due diligence of multiple institutions. There are disputes, and mainly it's regarding the land issue. In Pakistan, there is no differentiation that, when you want to run a commercial hospital, we need to know, which is the rule of thumb, in my view, that 20% should be or could be or should or must be capped at your real estate value. That if you want to start a project, then your allocation to real estate should not be more than 20%, because you have to spend a lot on HR and then your equipment, which is extremely important, but at the same time extremely expensive. So what I feel the most important thing is to getting the right real estate. And if I talk to the existing families who own middle-sized businesses, and we try to convince them to come with us, or we can unfold their potential, then their behavioral issues. Their openness. Most of the private mid-sized hospitals run double books. You have to convince them that you have to be fully compliant with all things. You have to pay your taxes. There is no over-the-counter cash, and so on and so forth. Then it's a difficulty. So in healthcare, the real issue is more towards and from the litigation perspective, that you find a lot of issues from all the legal side, and you don't have answers. And the person you're talking to, the entity, is generally not open to follow that well-compliant model.
I think I agree with you. If I could put the same question to you very briefly, for your product, for your investment style, what kind of return hurdles you look at, because that will also define the kind of funding sources you look for.
Naveed, was that for me, the question?
Yes, of course.
Okay. So we are a sector agnostic VC fund in early stage. And if you look at VC as an asset class, 3x over a 10 years cash on cash is, normally VCs would aim for. We'd hope that in an emerging market like Pakistan, where the opportunities, I would say, are more obvious, like I said, because of the late start, that we hope to do better for that. And in terms of what investors this is suitable for, I think this is for any investor that's looking to diversify into a very unique asset class, which is high risk, high reward. So eventually it goes all the way to endowments and DFIs. But like I mentioned earlier, we started with individuals and family offices. But as Pakistan startup ecosystem scales, I think any large endowments, family groups, DFIs, they should all be looking at Pakistan, because this industry, the current downturn notwithstanding, it will continue to scale. And Pakistani startups will create tens of billions of dollars in enterprise value over the next decade as the economy comes online. So I think it's an asset class everybody should be looking at.
So thank you very much. I really wish this conversation could continue. We have almost an alignment of thought process, in the sense that healthcare is a unique investment asset class. There's certainly need for center of excellences to be set up. There is need for hub and spoke models to be set up, and new economy health tech investments. Each have their own investor base, and the investor bases have been highlighted by the participants today. A very varied number of and type of funders have been on this call. We hope that the purpose of this study was, and this particular session was, to find and put people together on this platform forum and see if there is an alignment of interests or thoughts in putting together a programmatic solution across. So with that, thank you all, and apologies for the overrun on the time, but looking forward to continuing the dialogue offline as well with you. So thank you very much. Hassan, back to you.
Thank you everybody for joining. It was a very wonderful session, but unfortunately we're running behind schedule, so we have to cut this short. But if you have the time, once again, I would like to request you guys to check the questions in the Q&A box below and hopefully answer those questions before you leave. Thank you so much. And now I would like to welcome Ms. Anna Gibson for her remarks before we end this webinar. Ms. Anna is a Senior Private Sector Development Advisor at the British High Commission Islamabad, where she leads the private sector development portfolio. Previously at the Foreign, Commonwealth and Development Office, Anna was a lead advisor on British international investment, as well as leading economic development initiatives in Kenya and Rwanda. Prior to FCDO, Anna worked on ethical investment promotion in the private sector. And with that, I would like to request Anna to please. And unfortunately, I don't think we can hear you. I'm really sorry. No, I don't think we still can. There must be an issue at the mic at your end. I'm really sorry for that. We still can't. Could you, if you're wearing earphones, could you try plugging them out? Maybe there's something wrong with the mic. And yeah, maybe you can use your laptops. Yeah, now we can hear you. Perfect.
Thank you. Now?
Yeah,
right.
okay.
A good start on a technological discussion. But no, thank you so much, and apologies for the delay there. So I think, as we've all said, it's been a really fascinating discussion today. And firstly, I just want to congratulate Karandaaz and the whole team really for hosting this webinar and launching this important report led by the Center for Economic Research here in Pakistan. I think we've had a whole range of highly expert speakers who've shared their market-tested insight on the challenges and opportunities of financing, of innovating and delivering healthcare markets here in Pakistan. From the government side to fund managers to impact investors and innovative healthcare companies that we've heard from today. So it's been a really fascinating discussion. I guess also to say that the UK is particularly proud to be here today because we do support Karandaaz It's our flagship inclusive financing platform here in Pakistan that we've supported since 2015. So we're really excited to see this pioneering and market-focused research in the healthcare sector be launched today. And I guess we're keen that this analysis and the discussion doesn't just end with today's webinar, but it's really used to try and unlock key challenges and unlock key change in the public and private sector ecosystem of healthcare provision, really shift the dial using this kind of analysis and recommendations. I think one of the strongest themes that has come out of today's discussion is that we really do need all the different players from the government, private sector and development partners to play their part in transforming the healthcare sector. And we've seen that in the dialogue today, that we've had a range of public and private partnership solutions that have been recommended here. I guess we've also heard that there are quite a few roadblocks, a few challenges that have held back the private sector tapping into what is a very large market here in Pakistan in the healthcare sector. And that in turn has held back affordable access to the healthcare that's needed across the country, particularly for some of the more rural and underserved communities as well. So some of these challenges we've heard include a lack of standardized healthcare regulation, poor information management or weak interoperability of systems. And we've just heard from that last panel, particularly around a lack of risk capital and growth capital that's needed to innovate and expand private health models in Pakistan. And part of that is undermined by quite high costs of doing business, lack of supply chain integration, and lack of fit-for-purpose infrastructure. So there are a few challenges that have been holding back this innovation and this financing. And these are serious challenges because we know that the lack of accessible healthcare has indirect spillovers as well as direct ones. So we need a healthy workforce, we need this access to affordable, high-quality healthcare access to try and pay those wider dividends around supporting productive and sustainable growth. And I guess that is where the private sector comes in to try and harness the potential of innovative financing and more inclusive access to healthcare in Pakistan. So what we have heard from today is that there are also solutions to some of these challenges. We can bring together private sector stakeholders to collectively drive forward and advocate for better industry regulations, business environment reforms. We can support the better integration of healthcare supply chains, support the local manufacturing of pharmaceuticals and medical supplies, and that in turn then has wider job creation benefits as well as the direct benefits. And we've seen the importance of working alongside donors as well and development finance partners to provide that risk capital. And I loved hearing about some of the innovative medtech ventures that we had from today, particularly around the use of artificial intelligence to enhance diagnostics, really make the most of AI in the space. And also hearing about the home-based healthcare via telemedicine innovations as well, which both democratize that medical access and also have been empowering women to take up medical roles from their home as well that had been limited before. So there are lots of ventures there that we can draw on and learn from, but they do all require the type of higher risk financing to make them possible. So I did really briefly want to say that, through our support of Karandaaz, we've seen Karandaaz playing that role in providing the higher risk capital. We've heard that Karandaaz has invested in pharmaceutical manufacturing, so providing targeted support to players like Excel Labs to expand their affordable COVID-19 testing. And it's those types of innovations and investments that will crowd in other investors into the sector as well. Also to mention that the UK also supports wider support in the healthcare sector in Pakistan. We've got our flagship Delivering Accelerated Family Planning in Pakistan, the DAVPAP program, which has been supporting around 40,000 pharmacies to sell contraceptives and supporting private clinics to improve maternal health services. So there's lots that we're doing in both the public and private sector, particularly around supporting these public-private partnerships as well. And it would be remiss to also not mention British International Investment as well, the UK's development finance institution, who we have also heard from today, sharing their experience of investing all across the medical value chain and across different emerging markets. And they've got experience from their dedicated company MedAccess as well, which provides innovative financing mechanisms, procurement guarantees to help reduce the cost of medical supplies. So there are lots of lessons that can be learned from, drawn on here in Pakistan. And as we heard one of previous panel participants say, we can learn from those successes and failures and not replicate those and really use that as a springboard. So I think then only to say, as we close up today, there's been a lot of discussion around the growth and innovation potential here in Pakistan's healthcare sector. And we really hope that this report provides that foundation that others across the public and private sector can use to really drive forward innovation in the space. And we've heard about some of the cutting edge private sector DNA that has already been embedded in the sector so far. So I'm looking forward to seeing how the report's findings can be taken forward and really delivered in practice to support more inclusive, more innovation-driven healthcare in Pakistan. Thank you all. Thanks to Karandaaz, and I'll pass back over to you.
Thank you so much, Hannah, for your remarks. And I think on this note, we'll be ending this webinar. Once again, thank you to all our panelists and moderators, as well as other participants who joined into this valuable discussion. Unfortunately, we are out of time officially now, so we'll not be answering any more questions. But I believe my colleague told me that we have downloaded these questions and we will try and answer them via email or some other solution that we might find. And the report will be available on our website shortly. And once again, thank you so much for joining and have a great day. Till the next time.